Uh, the meeting's now being recorded. There you go. Thank you. As of now, so they missed the very exciting housekeeping. But I am now very, very honored to introduce a video by our own mayor, Mayor Michelle Wu, who took the time to record a intro and welcome video for you all. So I'll turn it over to the screen. Here comes the video. We'll turn it. All right. Well, we'll leave her beautiful face up. All right. So thank you to Mayor Wu for that incredible welcome. We really appreciate it. And again, a thank you to you all for being here at the Social Determinants of Mental Health Summit. I'm Samara Grossman, Director of the Center for Behavioral Health and Wellness at the Boston Public Health Commission. And it's really an honor to gather with you today. We're really grateful to Northeastern University, as I said, and especially to the Institute for Health Equity and Social Justice Research for being such incredible partners in planning this special day. So the Boston Public Health Commission, also known as BPHC, as you probably know, is the nation's oldest public health department. Our mission, which I'm very proud of, is to work in partnership with communities to protect and promote the health and well-being of all Boston residents, especially those impacted by racism and systemic inequities. Our vision is for every Bostonian to live long and to live well. That's why BPHC created the city's first population health equity agenda, addressing the social and economic conditions, housing, education, employment, and community safety that directly influence mental health and overall well-being. As director of the Center of Behavioral Health and Wellness, I lead a coordinated effort to transform behavioral health services for residents across the lifespan, with a current particular focus on youth. Our goal is to create a fair, just, and equitable behavioral health system in Boston. We aim to improve mental and behavioral health outcomes, particularly for those affected by racism and systemic inequities. We really are here to align with BPHC's mission in all ways. From healing-centered approaches in high-need Boston public schools to training youth workers and peer leaders, our work is rooted in equity, youth voice, and trauma-informed care. And we're here today to learn from each other, to share strategies and envision new ways to address social determinants of mental health, so that all Boston youth, families, elders, and communities have the support they need to flourish. So thank you for being here today. I hope it's an inspiring conversation. I feel like it's an important conversation. And I know as a clinician, it's a conversation I've heard time and again when I've been meeting with patients and hearing their stories. So I'm here to reflect their stories as well today. So I'm going to now I'm honored to be joined by our co-chair, Dr. Elisa Lincoln, Director of the Institute for Health Equity and Social Justice Research, here at Northeastern University. Lisa, thank you for being such a supportive partner.
Back to our title page. Thank you. So as Samara said, I'm thrilled to welcome you here to Northeastern on behalf of the Institute for Health Equity and Social Justice and the entire team who created this summit today. It has been an absolute privilege to work with our partners, the Office of Behavioral Health at BPHC, Samara and her entire team. And I also just want to do a special shout out for our advisory board, who really did a tremendous amount of work to make sure this event happened in the way it will happen today. So here at the Institute and at Northeastern, our teams draw upon a range of research methods and interventions with shared commitments to promoting health equity and social justice through high impact community engaged research. We've known for a long time, over a century, that the social determinants of health shape both individual and population mental health. Factors like poverty, exposure to racism in its many forms, other forms of social exclusion like heterosexism, anti-immigrant policy and practices, housing instability, job insecurity, and violence, including structural violence, all shape mental health and well-being for our communities. And while poor mental health and mental illness impact all communities, communities with fewer resources and who experience more discrimination and exclusion face greater barriers to mental well-being. And we know that in our city, often despite excellent clinical care, once people are struggling with symptoms of distress or mental illness, that our systems, often fueled by stigma or inadequate national level investment in mental health promotion, prevention, treatment, and recovery supports, worsen structural exclusion and further limit access to resources that promote health, mental health, healing, and well-being. Despite this, few of our efforts have focused on addressing these social determinants of health in the mental health space. So that's precisely why we are here today. The Social Determinants of Mental Health Summit calls us to look upstream, to address root causes that shape mental health and well-being for Boston's diverse communities. Our goals today, developed in collaboration with our advisory board, are threefold: to reframe mental health as shaped by the broader social and structural conditions of our lives, to connect across sectors and disciplines, public health, housing, education, research, community organizing, and to share strategies and collaboration. And as I look out across this room, I'm just thrilled at the ways we have people here from so many different spaces and the ways we're bringing lived experience to these discussions. And lastly, to move forward, we're hoping today is the start of a discussion that leads to actions and changes to move forward community-informed actions that advance equity and recovery. Lastly, today's focus on housing instability and economic security were chosen by our advisory board, and they focus on two of the most powerful social determinants of health, which provides us a starting point to diving deeper in understanding these factors and to make concrete change. I'm grateful for all of you who have taken the time to be here today in the room, and I believe online, as part of these really important conversations, for bringing your expertise, your experience, and your commitments to equity and justice so we can explore together how to create social and economic environments that promote mental health. So again, I really just want to thank everybody for coming today. And with that, before I do last introductions, I'm going to look at Samara and make sure there's no other housekeeping that I need to do. Okay. So it is now my pleasure to welcome two incredible leaders whose work exemplifies the spirit of today's convening. Dr. Kevin Simon, the Chief Behavioral Health Officer of the City of Boston, followed by Dr. Michael Curry, President and CEO of the Massachusetts League of Community Health Centers. So please join me in welcoming them.
So can everyone hear me? Awesome. So I'm Dr. Simon, and for those who are Haitian American or Haitian, Dr. Simon. And I am the Chief Behavioral Health Officer for the City of Boston, appointed by Mayor Wu, who we saw earlier, and practicing child and adolescent adult psychiatrist and addiction medicine physician, and regularly engage with patients and families around these kind of topics. And I'm told I can advance my slides. So if you need the program, and we've heard her. All right. So When we think about the social determinants of mental health, and as I look across the room, I see individuals from public safety, law enforcement, emergency services, housing, economics. And it is true that often when I engage with patients and families, and undoubtedly if someone's calling me for a resource, it's often not actually a resource related to a clinical appointment. It's a resource related to food. It's a resource related to a note for a 504 plan or accommodation plan at school. Someone's trying to understand really how to navigate this kind of maze that we identify as mental health system. And the fact that Samara and colleagues could convene us here today, it's literally in real form what it is that we're trying to do across the city. Because the reality is, again, Dr. Pierre that I see in his pink shirt, when he calls me, it's often not for clinical care. It's often for some other structure that impacts how our families engage. And so when we think about the social determinants of mental health, unfortunately, we recognize that they are unjust and unfairly distributed. And this is just a nice graphic, but we'll look at it and it says adverse built environment, neighborhood disorder disarray, environmental safety, homelessness, poor housing quality, food insecurity, poor and unequal access to transportation. There are patients that I have that are in the South End, and although my clinic is literally less than a mile away, it might take them actually more than an hour to get to me. And so sometimes I just get in my car, go to them if they can't make it to me, because transportation is a challenge. Low education and quality. There's oftentimes many an email I'm CC'd on from families who are reaching out to our Boston Public School colleagues, trying to figure out a way, how can the system help their son or daughter best get the education that the parents desire. And when we think about ACEs, or early childhood experiences, unfortunately, things that we see as little t or even big T traumas, a gunshot or an arrest, that doesn't just happen the day of and stay in the day in the past. It often is with the person. And again, when we engage clinically, we see it manifesting in how they interact with other individuals. And so all of these determinants can lead to, unfortunately, this idea of people making poor choices. But the reality is, if you're given poor options, well, you can only make poor choices. So what we're doing here is to think about how can we create better choices, better options for individuals and families to be able to have less psychological distress and ultimately less adverse mental health outcomes. And conversely, we're talking about systems. Well, people are within the system. There are people who are born with neurodevelopmental conditions, and the environment itself, if it's not catered to them, it will exacerbate potentially a distressing event in the school or distressing event in a corner store. So we have to think broadly about, again, the policies. And that's what I'm hopeful we're here for. When you hear the panelists thinking about what would it actually look like for Boston if mental health was really at the table when all policies are discussed. Because undoubtedly, mental health is at the table when all policies are discussed, but do we recognize it? And so I'm really excited to see what comes from this summit today. And now I'm most excited because I get to introduce a friend in Dr. Michael Curry, who's the president and CEO of the Massachusetts League. It sounds like a superhero team. And they really are superheroes because it's the state's entity with regards to community health centers. And again, when we're talking about social determinants, a lot of times I have to refer to Fenway Health or Whittier Street because it's there that I know I can trust there are individuals who are thinking holistically around our patients and families. So it's with much due honor that I introduce Dr. Michael Curry, President and CEO of the Massachusetts League.
So I'm going to jump right in because we only have a limited amount of time before we need to get to the panel. I just came back from South Carolina, where I was the keynote speaker at a conference. And what I say whenever I travel the country is, thank God I live in Massachusetts, especially now. Thank God I live in a state with a Chief Simon, with a Mayor Wu, with a Chief Ida Wu. I can go down the list. Because this is a critical time that we're having these conversations around health and equity in this country. And we're having it here in Massachusetts, and other people are hiding words and burying the data and not willing to have the conversations that we are here. So I want to start my remark off today as you get ready for the panel with a Rebecca Lee Crumpler quote. For those who don't know who Rebecca Lee Crumpler was, she was the first African-American female physician in this country in 1864. And I always say, for all the bad Black women in the room, you ain't as bad as Rebecca Lee Crumpler. We're talking 1864, on the heels of slavery, when women were not treated as full citizens in this country. And she became a physician right here in Massachusetts and in Hyde Park, where she lived. And she said, they seem to forget there's a cause for every ailment, and it may be in their power to remove it. They seem to forget there's a cause for every ailment, and it may be in their power to remove it. We're talking about diabetes, heart disease, cancer, lupus, name it. And I didn't really appreciate her words as much until I started reflecting back on my life. I grew up not far from here in Lenox Street housing projects, but when I walked out in my neighborhood and to my community, I didn't even have to leave my house. Diabetes and asthma and cancer and all those diseases were in our building. When I walked out in my neighborhood, I saw disease. When we would travel every summer down to Greensboro, Alabama, we would see disease, and I would see the sickness. They seem to forget there's a cause for every ailment. It may be in their power to remove it. I would travel to Minneapolis, St. Paul, or Youngstown, Ohio, or later to Howard University to visit friends at Howard and visit those communities in DC, and I would see the same disease. But it wasn't just physical disease. It was also mental health disease. They seem to forget there's a cause for every ailment, and it may be in their power to remove it. Let me get the next slide. So I want to share this quote with you. Dr. Jack Geiger, this is a historic moment we're in. 60 years ago, health centers were born right here in Columbia Point, where my sisters grew up. And Jack Geiger, one of the founders of this movement, so you see in this picture here on the upper left, is Bolivar County. That first health center, the second health center that was open in this country was in Bolivar County in Mount Bayou, Mississippi. So for all of us who grew up in Boston and projects, this was abject poverty down south, right? A whole nother level of poverty that we didn't experience as much here in northern cities. The two gentlemen in the middle picture is Jack Geiger, who was at Tufts here, went to South Africa, saw a model of healthcare, the Karks, a couple called the Karks, who basically started this model of health centers and would send community health workers, we didn't call them that at the time, into South Africa and those communities to treat patients. And he went on a fellowship in 1957 and saw this model and brought it back to Massachusetts, and then led this movement to create community health centers. There's a reason why I'm telling you 60 years later. And then there's a book that I would encourage you all to read called Out in the Rural that I use in my Suffolk class that I teach. But here's the quote: to treat symptoms and then send patients back unchanged in knowledge or attitude or behavior to the same physical and social environment, also unchanged, that overwhelmingly help produce their illness and will do so again, is to provide antibiotics for cholera. Think 1800s, London, John Snow. For those who don't know, the public health folks, the pumps were causing the disease. Is to provide antibiotics for cholera and then send patients back to drink again from the Broad Street pump. That was the source of cholera. Close the pump. So I say that as we think about why we're here today and the social determinants of mental health. One of the things I had the honor of doing is about a year ago, maybe a year and a half ago, I moderated a panel with Dr. Geronimus, who is the woman who's known for coining the phrase weathering. And for those who've never heard me talk before, it is by far one of the most fantastic concepts that I've ever heard because it explained my life. Now, when I think about those projects I lived in and those communities I visited, I think about the fact that we were weathered to disease. It was normal for folks to be suffering from schizophrenia or bipolar and dying of diabetes and heart disease. It became normalized for people to live less, 23 years life expectancy, as Dr. Ojukutu talks about all the time. When it becomes normal, you don't have a sense of urgency about it. In your family, in your health center, in your hospital, in your policy, there's no sense of urgency about saving lives. And remember, Rebecca Lee Crumpler said they seem to forget there's a cause for every ailment, and it may be in their power to remove it. So I want to just introduce you to this term weathering, and I want to read to you directly from Dr. Geronimus in her book, Weathering. Weathering, a process that encompasses the physiological effects of living in marginalized communities that bear the brunt of racial, ethnic, religious, and class discrimination. Critical to understanding and eliminating population health inequity, weathering affects human bodies and their minds, I'll add that, all the way down to cellular level. As they grow, develop, and age in a racist, classist society, weathering is not measured in the number of steps walked, cigarettes smoked, opioids used, alcohol drunk, or calories eaten. It is not primarily measured by your years of education, the size of your paycheck, or your bank balance. It's not essentially about emotional despair either. Weathering is about hopeful, hardworking, responsible, skilled, and resilient people dying from the physical toll of constant stress on their bodies, paying with their health because they live in rigged, degrading, and exploitative system. Here's why I'm here, and here's why I want to kick off your conversation today, and so appreciate Chief Simon and the Institute. I love this whole notion of causal chain. And as I was driving in today, I decided to do this for you because this is me, that little big head black boy from Lenox Street Housing Projects. The blame narrative, personal responsibility, pull your pants up, eat right, takes no consideration into the injustices and the discrimination in our society. And the researcher that I was listening to on the way in talked about the causal chain and thinking of it in terms of the toddler who always asks the question, why? Right? Any of us who have kids, they just barrage you with why? So I'm going to tell you about my sister, Veronica. We called her Ron, who is often in the hospital. Literally once a month, we were in Boston City Hospital with her with asthma, tie it to mental health. The toddler asked, why is Ron in the hospital again? And the mother answers, she has asthma. Why does she have asthma? I don't know why she has asthma. I think they tell me because we have roaches and rats in the house that make her sick. Why do we live in a house with roaches and rats? Because the people who manage this housing projects in the city don't exterminate, and they don't care about Black and brown folks living here. Why don't we move? Because we're poor and we can't afford to live anywhere else but here. Why are we poor? Baby, that's complicated because throughout my life, people who look like you and me were stuck with bad schools, unsafe neighborhoods, bad health care, bad jobs, bad housing, and we were treated differently. Why were we treated differently? Because somebody determined that we didn't deserve to be treated the same. That was mean, that little toddler would say. So when we're in this conversation today, I want you to think about mental health, and I'm gonna leave you with a personal note. Just 2 weeks ago, 2.5 weeks ago, my sister died. I'm gonna get emotional. I wasn't gonna get emotional when I was gonna tell the story. My sister passed away. And she had diabetes, had some mental health issues, on medication. She should still be here. But she wasn't managing her mental health. And because she wasn't managing her mental health, she wasn't managing her physical health. That's why she's not here. And when I think about Thaddeus, when I think about the impact of her death, it wasn't just about my sister. Her son didn't come to the funeral because her mother was addicted to drugs most of our childhood. And he never got over what he experienced with a mother addicted to crack. her daughter-in-law didn't come because she felt that the mother of her kids, her grandmother of her kids, didn't care about her children. So her children weren't at her own funeral. Her grandbabies didn't come to her own funeral. I'll end it on this, is that there's a thing in the Black community, we say Black don't crack. And it's the resilience of our skin. It's the fact that we survived slavery, 1619 to 1865, Reconstruction, Jim Crow, racism, busing. But I always tell people, Black don't crack, but the cracking's on the inside. Everyone would crack to endure those circumstances and those conditions: poverty, housing insecurity, food insecurity, racism, violence, trauma. We have to have a conversation. So as you get ready to sit down with the panel and to have this conversation, I have to ask the question, what are we weathered to? What have we become weathered to? And as I have been a champion for this health equity movement here and across the country, I ask you, where's the political will to do something about mental health? Because I would argue it's the caboose of healthcare. It's the afterthought when we talk about diabetes and heart disease and cancer. People go, oh yeah, what about that mental health thing? But I would argue, in the spirit of thinking about my sister, you can't have physical health unless you got mental health. Thank you.
That was so powerful. Thank you. Thank you both. Whew, let's take a breath, take in all the stories, the meaning of what he just shared. I really appreciate that. So thank you, Dr. Simon and Dr. Curry, for your leadership and your words. You've set, obviously, a very powerful tone for today, and exactly the reason that we've come together today to talk about this explicitly. So we're now going to turn to our first panel discussion, and I'm very excited to introduce our first moderator, Chief Segun Adowu, Chief of Economic Opportunity and Inclusion for the City of Boston, who will lead today's panel on economic insecurity and mental health. You can learn more about each of our panelists in your virtual brochure, so I hope you'll check that out, because all their bios were too long for us to be able to fit into the timing today, but these are very esteemed panelists representing a real diverse cohort of perspectives. So please come up to the stage, panelists, and Chief Adowu. Thank you.
Morning, everyone. Come on now. Now, if this were dinner time and all that, I would get the lack of enthusiasm here. But there's coffee and nice flavored water and croissants. Good morning, everyone. Wonderful. Great to see you. First of all, I want to thank Dr. Lincoln and want to thank Northeastern for hosting us this morning, and especially want to thank Dr. Ojikutu and the Boston Public Health Commission and the team for putting together this conversation today. I'm going to say Dr. Simone, because if there are Nigerians in the room, you know, that they're going to get on me for how I say my name. So Dr. Simone, who's a wonderful colleague of mine in city government, and then my chosen brother, is a president doctor or doctor president, but Michael Curry, who is on the front line. So I know he's here right now. He's probably going to head into the office shortly, but then he'll be on a plane to some other part of the country, because I got to know Dr. Curry as a member of the local NAACP chapter, and there are many throughout the city who were members of the chapter then, and but he's taken that leadership to the national level, and so he's on the front lines. So all the things that he was talking about are not just part of a presentation, it's lived experience and things that he's doing every day. I see other members of the city team that are here this morning. I see Frank Farrow, who's leading Black Male Advancement, and the team here, if you just want to at least let folks know that you're here. And if there are other city members, I just want to give an opportunity to make yourselves known. And okay. Again, my name is Shigun Idiwu. For the last 1,387 days, I've had the fortune of serving as the Chief of Economic Opportunity and Inclusion. And if I were here 4 years ago, I would have said I'm the Chief of Economic Development. But when Mayor Wu assumed office in November 2021, in that 2-week period, she had less than 2 weeks to transition to the role. We met, and she wanted to change our name, and we landed on the name of Economic Opportunity and Inclusion. I wish we had been more thoughtful at that time, because now instead of OED as our acronym, it's EIEIO. But you'll remember it though. But the name was changed for the very real reason that was the common understanding of both of us, and I think everyone in this room and who's watching online, that the idea that the development of some communities cannot coexist with the underdevelopment of others. That here in the city of Boston, a city of tremendous wealth, that the neighborhoods of Back Bay and Seaport and other neighborhoods will never ever reach their full potential if the neighborhoods of Roxbury and Mattapan and East Boston remain underdeveloped. And so all of the work that we've been doing for those 1,387 days has been working to ensure that the immense wealth that the city sits upon is also making it to neighborhoods that for a long time have not had an opportunity to participate. And so that's all the work that we've been doing. I won't go through all the stuff that we've accomplished. I will name two. As we're thinking about health and wealth and abolishing this economic insecurity, our work focuses on small businesses, not just bringing companies like Lego and Hasbro, even though we're very happy about that, but we're all about serving the 18,000 small businesses that are employing 127,000 people and generating $28 billion every day. That's how we're making sure that our communities are no longer economically insecure, because a lot of folks develop their wealth through starting small businesses. And so just in the last 3 years, not even 4, we've delivered $35 million to 1,500 businesses, with 70% of those businesses being owned and operated by people of color, 52% being owned by women. And then on the contract side, which I'm very excited that the Black Economic Council of Massachusetts is represented today, in just those 3 years, contracts valued at $630 million being awarded to businesses owned by women and people of color, compared to the previous 4 years where it was less than $350 million. And so we're proud of the efforts that we've done in just a couple of years, and we're excited that we have a little bit more of a few years to continue delivering for the 716,000 residents of the city of Boston. That all said, health is wealth and wealth is health, and we're here to talk specifically about mental health, which I think is really, really important. And I agree with Dr. Simone and with Dr. Curry and all others that have come up to say that this is a topic that we don't often talk about, not just in the Black community, but all over our communities. And so I'm happy that we're spending the day talking about this. I want to introduce members of our panel who are here this morning. I did all the talking because this is the last you'll hear me say anything of note. The real experts are to my right here. I'm just going to say their names and what they're representing, but we'll start digging into the questions, and I'll have them say more about the work that they do. But to my right, I've got Magali, who is now one of my favorite people. She's a constituent. She's a resident of Charlestown, a mother of 4. She's here representing the lived experience that she'll be sharing with all of you. To her, oh, okay, great, yes. I've got Jenny, who's the assistant professor of psychology in the Department of Psychiatry at Mass General, who's joining us. I've got Cyril, who's the senior vice president of programs and services at Harvard Street Neighborhood Health Center. And one of my other favorite people, Alyssa, who is the director of, chief of policy at the Black Economic Council of Massachusetts, otherwise known as BECMA, who's joining us. And the roles are reversed. Usually I'm on the panel and she's moderating, and so I get to, be the hard one and ask the tough questions. So thank you, Alyssa, for joining us. So I actually want to start our questioning with Jenny here. I'm wondering from your vantage point, from your experience, how you've seen economic insecurity magnify the distress and poor mental health that we've seen in our communities, particularly those communities that are experiencing discrimination and systemic racism.
Thank you.
Excellent.
Okay, great. I had actually prepared my talk a little bit different, but I'm gonna been really inspired by the keynote speakers and they're sharing their experience. I want to share a little bit of my lived experience because I think it'll make more sense of the work that we do, that I do, and that we do at our lab. I was born in Colombia in South America, and I grew up in Puerto Rico. You usually don't think of someone that Puerto Rican looks like me, but I am. I am also a native Spanish speaker, and for almost 20 years, I have been studying Latino mental health. And I'm also a clinical psychologist, and I provide therapy in Spanish and English at MGH right now. I see mostly Spanish-speaking patients, but I have historically seen Spanish-speaking Latino patients. A lot of them are undocumented families. And before MGH, I was at BMC, and I think about, and on the way here, I was just really thinking about how difficult it was my commute from JP to BMC when I was there, and how easy it is for me to go to MGH because I just hop on one train and I get there. And I think about the social determinants of health and how that really impacts everything, right? Like how it really seeps into our everyday life. But I was also, as I was hearing the keynote speakers, I was also thinking about when I was a PhD student in Cincinnati and how I used to perform psychological testing just to test for school readiness on low income schools, like preschools. And I remember testing in a preschool that were all 3 and 4-year-olds, and I was testing them to see if they're ready for kindergarten. It was a very, very low income area, and I have volunteered to do this because I was very interested in doing this and working with little children, and they're really the cutest too. And I remember doing testing, and suddenly all the teachers start like freaking out, and I was like, what's going on? What's going on? So there was a shooting right outside of the school, 3 and 4-year-olds, and they were all panicked. But then I was talking to the teachers, and apparently it's a very common occurrence. 3 and 4-year-old, all of them Black kids. And I really think about how when we think about social determinants of health, how this is not only just having less income, it really seeps into every single day of people's life. When you think about systemic discrimination, structural inequalities, it really seeps into everyday life. I grew up myself low income, but this is on another level. And I think I'm preaching to the choir here because a lot of you understand this, either from lived experience or from people that you work with, but it's very hard to explain to people how much of this really it's like all encompassing. I'm also a clinical researcher, and today I think I'm going to mostly focus on like what have we done in terms of research to solve some of these problems. How can, instead of focusing on the problem, which we all know, I think I'm going to focus more on the solutions and what are some of the work that we've done. One of the things that from the data from the 2019 census, researchers have found that 14% of children live in households below poverty level. And of those children, 3/4 of those children are from racial and ethnic minoritized backgrounds. And I think this is not coincidental. We think about social determinants about affecting every aspect of their life. And in fact, like children and adolescents from low income backgrounds are 2 and 3 times more likely to have mental health problems than their middle income peers, but they're also disproportionately less likely to seek appropriate mental health care. And I think about my work as a clinician, and I am trained as a clinical psychologist. I go to school, and my teachers teach me to sit in front of the family or the client and talk about their mental health. And I've always been trained this way. I've always been trained to sit and think about their problems, help them cope, and all these things, which are great. But my experience as a clinician working with people from low-income backgrounds is that what was most effective, what was most helpful to them a lot of times is spending most of the chunk of the hour helping them, connect them to services so they can get enough food, call their doctors with them because the doctors don't want to listen to them. I have gone to school meetings with parents and the children because the clients and the families are telling me they don't believe me that the kid is having problem, that I'm trying my best, that they're blaming me for because the kid is not doing well. So as a clinician, even though I've been trained to sit in front of them and teach them, like, let's take a deep breath. And these are great strategies. But the reality is that as clinicians, as researchers, we have to match the service we provide with what people are needing at the moment. And so I'll stop there. One of the research projects that we did at it was with youth. It was a photo stories project from our lab. And we gave cameras to youth across the greater Boston region, mostly low-income regions, for them to take pictures of their community and ask them to explain to us what they see and why were these pictures meaningful. This is a participatory action research project, and children and adolescents across greater Boston took pictures of their community. And what they found is that the local conditions, their community conditions, are linked to their mental health, both as a protective factor. A lot of youth said these outdoor spaces are crucial for my mental health. They're for me to spend time with my friends. They're for me to stop thinking about all the violence that's going on in my home, think about the poverty that I'm experiencing. But also their communities is also a source of risk factor. They took pictures of maybe broken playgrounds and thinking, this to me means that the city doesn't care about me. They don't care about the children in this community. So I think there's a lot of opportunity to really ask people what we think the solutions are, rather than, as someone who's trained as a community-based participatory research, I always say, I'm not the expert. I'm not the person with the lived experience. If we only take some time to ask people what the answers are, I think there's a lot of opportunities to growth. And from that project, actually, and driven by what the youth were saying, is that they wanted to be more civically engaged, civic participation. So we started doing an after school, and from my lab, we started doing an after school civic engagement intervention where we're embedded in different schools after school program to teach them how to be more proactive and making changes in their own local, hyper-local communities. And that has shown that the more children and youth and people in general feel that they have some power to change their environment, the better they feel about mental health, about themselves, and the better health outcomes prospectively. I'll stop there. Thank you.
No, that's great. And so, I'm going to pick up on the last point you made. I'm going to come to you next, Cyril. One thing that Congresswoman Presley talks a lot about is that people closest to the pain should be the ones, guiding and building the policy. She's also focused on data and making sure that that we're all taking a data-driven approach to the work that we're doing. And I know, Cyril, at the Harvard Street Neighborhood Health Center, which is a huge partner of the city, we appreciate President Murphy and the team for what they're doing to work with the Health Commission, especially on this initiative to extend life expectancy across our neighborhoods. But I'd love to hear from you on the data piece. I'm wondering, how neighborhood level mental health data, can help guide some of the strategies that we're talking about today.
Good morning, everybody. It's good to be here. I'm a Husky myself. I was here back in from 2005 to 2010. I graduated from counseling psychology PhD. And yes. So I was just talking to Dan a while ago. I'm like, has things changed? I said, yeah, there's some few changes, So I left Northeastern and started working for Widow Street Health Center from 2010. After 10 years or so, I left and also went to Harvard Street. So I grew up in a health center working for working for the community, and then saw through the the inequalities in the community, the stress in the community, and dedicated my life to programming and things that could change people, not just one at a time, but at least so many at a time. So I went ahead and got an MBA so I could just, do some more work. And thank you, Michael, for what you've done. Thank you so much. You've really come together to, like bring health centers to provide more services to the communities. Health centers are the entry point for most individuals, especially of color, right? Not everybody can afford to go to the big hospitals. Not everybody can afford, private insurance. So where did they go to with mass health, right? The health centers. And I can tell you, when I spoke to patients and then, someone has $5 left, right? And they either go to the hospital or buy milk. What do you think they would do? Buy milk, exactly. So when we talk about things, social determinants of health, and then equity, you have to think about what do you provide to the community to be equitable to everybody else. You don't give everybody the same thing, you give them what they need, right? But there's also systemic issues that are in there. So come to the data. The data actually tells us what is happening. Data will tell us about, the housing crisis, the job, the unemployment rates in the community, the lack of housing, that is there, and the healthcare as well too. So, and then I start looking, how do you start addressing some of these issues one by one? What can the system do? What are policy changes that we need to do to address some of these issues? Let me ask you guys one simple question, please, right? As a student of Northeastern, I was involved in a project, reentry program at South Bay House of Corrections, right? Oh my God. Okay. So I saw so many kids locked up in that place. And I'm wondering, like, all these kids are supposed to be out on the streets. Do you know how much it costs to put one person in prison for a year? Please. Random, how much? Melissa? Maybe more? Exactly. Over $100,000 to keep one prisoner in prison for a whole year. Take 10 of them, just take 10, 1 million, right? You can do more services for individuals, yeah? So that's what I'm asking. Let's think about those type of policy changes. You arrest people for so many small things, and then what happens? They come back, they lose the insurance, they lose the ID, and then have to start all over again. And the system repeats itself over and over again and again. So housing crisis, trauma in the community, all these things lead to mental health issues. They become anxious, they become depressed, they become traumatized, and then, they won't seek therapy. They take it out on stuff like violence, on crime. And then the circle keep on going on and on again. So these are some of the issues I think we need to address, if we're taking seriously the quality of life of the minority population, in different races. You all know that the life expectancy in Roxbury, Dorchester is way, way lower than the life expectancy if you move a little bit here in Back Bay. These are things we need to think about and then find a way to address some of these minor issues so we can have better quality of life for the underserved. Thank you.
Well, I thank you for that. And so we've heard from Jenny in terms of her experiences engaging folks in community. We've heard from Cyril on the data-driven approach and how that should guide the work that we're doing. But I'm wondering from the truly lived experience from one of our panelists up here, first of all, coming from a really important neighborhood in the city of Boston, which often gets overlooked and really shouldn't. And I'll say that, this year, Philly thinks they started the country, but we all know that Boston is where the action happened. And this year, the 250th celebration, everyone else is going to be celebrating next year, 2026, because that's when they got involved. But we kicked it off here first. 1775 Battle of Bunker Hill, which happened where? In Charlestown. And so, Magali, I'm so happy that you are able to join us this morning. And I'm wondering, from your experience, particularly your family experience, how you've seen stigma related to mental health impact or relate to economic insecurity that you're seeing.
Thank you. My name is, hello everybody. My name is Magali Galvis, and thank you so much for having me here and giving me the opportunity to bring my perspective to this very important conversation. Okay, gracias. Thank you for Johanna being here and my son, who is my inspiration, and everybody else too. Thank you. Thank you so much. I am proud. I am the proud mom of 4 wonderful children. My older kids are over 18 years old, and my youngest son, who is 16, struggles with mental health challenges. He's a bright, funny, and loving kid, but some days are really hard for him. He deals with deep anxiety and emotional ups and downs that make it hard to focus in school or be around other kids. There are mornings when he just can't bring himself to go to class, and people don't always understand that. Sometimes teachers or neighbors think he's just being difficult, but I see the fears and sadness in his eyes. As his mom, and all I want is for him to get the help and understand he deserves, not judgments or labels. Living with that kind of pressure takes a toll of the whole family, especially when you're already struggling to make ends meet. There have been times when I didn't know where to run or turn, but I have keep pushing because I love my kids more than anything, and they deserve. Oh, oh. Ay, por favor. Thank you. There have been times when I didn't know where to turn, but I keep pushing because I love my kids more than anything, and they deserve to feel safe and supported. Families like mine face both emotional and financial struggles, but our voices matter, and that's why I'm here to help people see what's really like. It's been really hard watching them go through things that people don't always understand. My youngest son has bad anxiety and also PTSD. Someday he just can't face school or even get out of the bed. People sometimes call him lazy and think he's not trying, but they don't see how much effort it takes just to go through the day. Another day of my kids went through depression. Sorry.
Take your time.
My kids went through depression, and others acted like it was something to be ashamed of. a kind of judgment to close doors to jobs, to school support, and to understanding. And when you're a mom trying to keep the family afloat, it takes a toll. I have to stop working because to take care of my kids on the hardest days. No work means missing paychecks, and the bills still come. The stress builds up, and you start to feel trapped, like the stigma and the money problems feed off each other. It's painful cycle that so many families like mine fall into. I think what we need most is understanding and compassion. People need to see that mental health struggles are real and it can happen in any family. It will help so much if schools, workplaces, and communities are more open conversations about it. Teachers and employers should be giving training to better support people dealing with mental health challenges instead of judging them. I'm sorry. And we need more affordable care, counseling support groups, access to therapy that you don't have to wait 6 to 12 months, and services that family like mine can actually reach without worrying about the costs. Having someone to talk to, someone who listens without judgment, can change everything. If our communities show more patience, kindness, and awareness, families like mine wouldn't feel so alone trying to help our kids through tough times. Thank you so much.
Well, I want to thank you for not just sharing your experience, but being vulnerable with us this morning, and reminding us, a lot of times when we have these conversations, especially in stuffy rooms, back in City Hall or the State House or other places, these become just about numbers, and what are the facts and the data, and it really causes you to forget these are people's lives we're talking about. This is a lived reality for too many folks, and I want to thank you for reminding us of that this morning. And that's why, Alyssa, I want to come over to you now. And by the way, this is my last question that I'm asking of the panel. I hope all of you have been thinking about questions. And there will be someone with a microphone. And I'm saying this in advance of the last question. When we start going out to the audience, no speeches in search of a question. All right. We want you to have real questions for the audience, for the panelists here, because we want to kind of dig down into things, and walk away this morning or this afternoon with some things that we can take back to City Hall, to the Health Commission, to other parts of government, and the private sector and other places to really work on together. So Alyssa, I'm going to come to you for this last question after hearing all that we've heard this morning, and thinking about how public health, how the financial and housing sectors can work collaboratively to improve and create, better mental health outcomes. How can we leverage this push for economic justice to see it as a mental health intervention?
Thank you for the question, Shagun. And usually you are the panelist and
Mhm.
I am the moderator. So it's interesting to look at you from this angle. I do want to thank our panelists here. Thank you for sharing your story. I truly believe it's one of the hardest things we could do is to share our story, especially in front of people. But there's power in sharing your story. So thank you so much.
Oh no, you did an excellent job.
Oh, you did a
Excellent
great
job.
job. You did a great job. Thank you. Also, how much time do we have? Because I kind of have a couple things to say.
Yeah, you got 2 minutes. I'm kidding.
It's not going to work. Sorry. A little bit about myself. My name is Alyssa Benelfi Ramos. I am the Chief of Policy at the Black Economic Council of Massachusetts, or BECMA for short. There, I'm responsible for our statewide public policy advocacy. and I meet with legislators, I build relationship with different government stakeholders, and I attempt to get policy and legislation passed, at the city level here in Boston, across the state at the legislature, and sometimes occasionally at the federal level. So that's a little bit about the work that I'm doing. A little bit about me as well. So, what really got my interest in mental health started when I was actually doing my graduate practicum. I was working at the Sexual Assault Responsive Prevention Center at BU. And there is where I realized just how important it was for systems to not replicate systems violence when folks are seeking services. And that got me really, really passionate about trauma-informed approaches and how we need to ensure that everywhere, whether it's after school programs, city services, any of these things, that they're trauma-informed. I also care a lot about community health centers because my undergraduate internship experience was at the the Edward M. Kennedy Institute for the United States Senate, where I was an intern learning about the role of community health centers and the role that Senator Ted Kennedy played in getting them, in Massachusetts and everywhere. So that inspired me to do my other practicum at DIMIC. And I spent a lot of time at DIMIC doing social determinant of health screenings. I say this because the social determinants of health is everything as we think about public health, but I'm going to introduce a couple more things too. Lastly, I am half Jamaican and half Ethiopian. And when people usually talk about public health or public policy, they're like, oh, what's your area of interest? What are you passionate about? And some people, it's like Medicaid or, data. Sorry. And for me, it's always been, I just want to help Black people. I just want to help people of color. I want to help immigrants. I want to help queer people. I want to help youth. I want to help the elderly. So for me, whenever I approach public health issues, it seems to be very broad and interdisciplinary because that has always been my mission. And we could do that in whatever arena, like let's talk, let's play games. So that being said, thank you for letting me be here today. I want to double down on how racism and discrimination are a form of toxic stress. And we know that when racism and discrimination are forms of toxic stress, that's been combined with folks experiencing mental health challenges, experiencing homelessness and other things like economic insecurity. So there's that compounding impact and the weathering effect that Michael Curry spoke about earlier. When I talk about weathering, I think about like, what if you have a stone and it's sitting under a faucet and every day water is dripping onto that stone in the same spot? What happens to the stone? It erodes. It shows wear and tear because of that dripping of that faucet. And so it's so important that we talk about economic insecurity and poverty as public health challenges that need to be addressed with urgency. I'm a millennial. My notes are on my phone. So traditional public health must partner with finance and housing to design and implement solutions that will create equitable mental health outcomes for all and center people's lived experience, justice, and share power. I find that almost everyone I come across, either themselves, they're impacted by mental health challenges or illness, or someone in their family is. But when we have these conversations, we're often doing it in a really compartmentalized way, like a very academic, like let's have a thought exercise kind of way. And I like that today. I've been seeing people show emotions. I have 1 minute. Okay. Basically, I just want people to close their eyes and think about everything you've heard over the past hour. What would it look like to have equitable mental health outcomes? Okay, write that down. Now, my work at BECMA is centered around closing the racial wealth gap. And how do we do that? We do that in a multitude of different ways. If we look at our communities, we know that they're impacted by lower wages, lower educational attainment. Without intervention, the median Black household wealth is on a path to hit zero by 2053. So the work that we do is incredibly important, but it also requires centering justice. It's not about just helping individuals cope. It's about reorienting systems and dismantling these systems and building new ones and switching up how institutions operate. Many of you, talk about, oh, well, the system is the way it is, institutions are the way they are, but institutions are made up of people who are making decisions. Justice can look like redistributive, like universal basic income, or a fair share millionaire's tax, or procedural in nature, like participation in meaningful community engagement. So not one-offs, but building established networks. It can look like investing in communities that have lacked investment, like Live Long and Well, BPHC's agenda. We have to speak out about what's impacting our communities. I'm going to skip quickly to strategies. I think about these things as the political determinants of health in addition to the social determinants of mental health. When we think about political determinants of health, if I was to sum it up, it's about government action or inaction or neglect that is impacting people. Policy impacts people's lives. And I think sometimes when we talk about the social determinants, we're not talking about who the actors are behind the social determinants. So I want to just remind us that there are people who make decisions. Some can be positive, like Shagun was talking about earlier, and others that are negative or neglectful that negatively impact our communities. We also have to think about the commercial determinants. So corporations, companies, private equity, what is their role in driving, influencing behavior, decisions, access to resources, and access to care. So when we're thinking about policy solutions, we have to think about not only the social determinants, but the political and the commercial. Skipping to the end. There's a lot of strategies. I'm happy to share those when we answer questions, but public health can use data to create metrics that allow for us to look into social and psychological well-being when we give out funding. That's an easy thing that we can do and ensure that when we're giving out funding, we're holding folks accountable to use it the way we're supposed to. If we're going to do things like social determinants of health screenings, let's do them in mental and behavioral health settings. But how are we ensuring that we're then actually connecting people to resources? Things like financial navigators, benefits coordination, free legal aid, eviction prevention funds, and other longer term resources to get folks so they're not spending their appointments getting only social determinants of health related support. There's a whole panel on housing. I'll skip that. And then lastly, finance. We need capital. You can't make money without having money. So how are we getting creative with funding? Seeing things like community empowerment and reinvestment dollars for maybe cannabis regulation utilized for housing or mental health. How are we seeing about Community Reinvestment Act dollars from local banks to be introduced and utilized in new and different ways? How are we relying on community development financial institutions, even though Trump is defunding those, to prioritize small and diverse businesses, community ownership, co-ops, and community land trusts? And how are we going after philanthropic and corporate social impact dollars, state money, federal money, unrestricted money, braiding these funds together? And then just speaking broadly, what about like guaranteed income programs and using public dollars for crisis response and prevention, things like childcare and elder care, baby bonds, first-time home ownership programs, foreclosure prevention. There's so many things we could do to address people's mental health. And when you start talking about it, people don't think you're talking about mental health because you're talking about housing and wages and resources. But these are the conversations that I like to have and link them back to mental health, because if folks have stability, folks can focus on trying to get well or being well as they'd like to be. And I'll leave it there.
Thank you. Thank you very much. I'm scanning the room to see if there are any hands for questions for the panel, which is weird because this is not a shy crowd. I know a lot of y'all. Well, let me, oh, okay. I see your hand right here. Ms. Grossam's going to come with the, oh, there you go.
So we have, I think, time for maybe 3 questions that we'll do from the in-person audience, and then we'll try to do 3 from the online audience. So I guess it's first come, first serve. So get your hands ready and I'll scoot over to you.
And if you could say your name, who you're representing, and then your question.
Sure. Good afternoon, everyone. My name is Daniel Callahan. I am representing myself.
Excellent.
We had just an incredible story shared from somebody who is right now going through a lot. And I just am really interested in us focusing on how we could actually provide services for this woman and her family. What could we do now as a community to help this individual?
Good question.
I am kind of sad because I'm here, but we're having some struggles with my son. I don't know. Would you like to say? Yeah. Well, can you share? We're Let's see. We're having issues with the school about the phone changes, you know, and he's very attached to the phone, and he has some traumas to from school to from the bus to the schools, and he doesn't want to turn his phone because a lot of stuff have happened in the bus, and he's being he goes to a therapeutic school, but because he doesn't give the phone, he's being isolated in that school, which I don't understand. If it's a therapeutic school, how can you keep somebody isolated? And especially if you have PTSD and you have an IEP. And I have told them, so that's what really hurts me, you know. And it's not only him. I guess it's other more kids like him that it's gonna happen to them too. You know what I mean? I know, I know. It's good to not have the phone, you know, which I understand. But for him, he's also in the spectrum too, besides mental health. So it's hard to when he's dysregulated, which other people don't understand. They said that it's a troubled child. It's not trouble. The way they see things is very different from us. We need to learn from them, teachers, doctors, and everybody else. Um, I'm a new parent. It took me three diagnoses. I had to switch hospitals because I know he had besides his mental health, he was in a spectrum. But finally, I got it 3 years ago. So he lost all his learnings when he was little. I fought with BPF for 10 years to get a therapeutic school. Now I got a therapeutic school. And the problem hasn't solved the problem. And I'm still fighting because if I ever die, I want him to be teach the right way so he could survive the world because it's not easy. And because I love him so much and I want to advocate for other people too. I volunteer for people and I thank you, Johanna, because you've been there for me. You've been teaching me everything, how to fight the system, get free advocates, and don't be ashamed of going getting help because you need family support. Because if I didn't have Joanna, I think I would have been dead with stroke because it's not easy. It's not easy. But I'm here for him and other families. If it takes a village, we go and fight for the village and be united. Thank you so much.
Thank you so much. Very powerful answer. And you can hear in what she said, think about it systematically to take the points and think, what do we all need to do to make those things happen? Time for one more question. Yes.
I wanted to add to your question and to all of you that what we need is a lot more collaboration. We need to have these conversations more often. We need to talk about education. You need to find lived experience, you know, as we are going to look for more funding, you know, lived experience. I'm here representing PAL, the Paraprofessional Advocacy League, but my passion in working at PAL comes from my lived experience, my own struggles, you know, my own, you know, I'm an immigrant from Honduras, you know, I came here with stigma and everything around mental health, and I'm a fierce advocate today around mental health because of the collaboration, because of the patients I received from providers like yourselves. You know, when I went to, I had a family partner, remember, that told me, this is how we do it in America. And I'm like, well, this is all new for me because you guys talk about mental health like it's something normal and that is not normal for me. But it was, you know, I changed my profession to do what I do today because it became part of my life. You know, it became part of my routines, like, you know, like my children, you know, like now my today, because of all of the resources, because the patience, the collaboration, the understanding, the education, I'm able to give it forward. Okay, but my story is not unique. Magali can be, is the next one, and any of you. And one of the things that I loved about this panel today is that every single one of you has some sort of lived experience. With the lived experience comes passion. With passion comes you get things done. I know I got things done. I thank God every day that I'm able to give it forward, that I'm able to support families, and that I'm able to collaborate with all of you. You'll see me everywhere in Boston trying to collaborate, trying to connect with all of you, and trying to figure out how we're going to help a family like Magali's. So what can you do? Even if you can tell me, I can go to her house and make lasagna. There's a place called Lasagna Love. Sometimes you can cook, okay? Or I'm going to be by her side and go to the school. Or I'm going to go to the hospital to get an evaluation. Or I'll be there when the child gets hospitalized. That's what I've done, and that's what I hope for everybody.
Let me just add one, Suzanne, let me just add one thing from somebody who works in a health center. And I can tell you, so we do have a lot of people that come in for social determinants of health. That's the entry point, right? They're dealing with transportation issues, they're dealing with immigration issues, they're dealing with housing issues. And then we have, community health workers who do the initial assessment. But then, as you're doing this assessment of social determinants of health, you find all kinds of other issues, mental health, for example, which is major. So, we call it integration into behavioral health. So someone does a quick assessment and they get into therapy. So all I'm trying to advocate here is that as people of color, we are not interested in mental health, but a lot of the issues that we're dealing with is mental health. So at Harvard Street, we've seen that, like I said again, we've seen that entry level, and then we'll connect people right into therapy. And therapy, some of people, because of stigma associated with, with mental health as well too, they don't want to come in person. So thank God for COVID, right? I mean, I won't say thank God for COVID. It opened up Zoom, it opened up, telehealth. So telehealth is a very good system, actually, good format for people to stay and get, help, get mental health. Because a lot of the kids now or even parents who don't want to get into the bus, get into the car, and then go for mental health can stay at the comfort zone, their home or anywhere, even on vacation, with a phone, with a video, and then do therapy. They still get the same therapeutic effect that they're getting, even when they're in person. And as you're talking about social determinants of health, that takes away even the fear, the anxiety of, the financial, stress of traveling, on the buses. There's no transportation. There's no stress of getting to the bus, phobia taken away, and still even the time that you also waste. Stay at the comfort of your home. So if going to therapy, for your family, for your son, is problematic by going in person, do telehealth. They will still get exactly the same effects. So thank you.
I wanted to add something to both Sybil's and Magali's point is that when I worked at BMC, I worked in integrated behavioral health. This is like more atypical than like seeing your therapist one-on-one. Like the patients came to see their PCPs. The PCPs assess and they think maybe they have some mental health needs. And they were like, you're going to talk to a friend. I was a friend. So, and that's the way they got connected to mental health. And it was extremely efficient because the stigma was reduced because they're just talking to me. And they're like, I actually really like talking to you. I'm going to come back next week. So the type of interventions that I'm delivering right now is actually to be delivered in usual care setting. What does that mean? I volunteer for the Home for Little Wanderers. I do Spanish groups right now. And I want the families that come in on Wednesday to pick up their diapers to be met with someone that is like bachelor level or like high school level trained community health worker, delivered an intervention that I've proven that this has good advocacy. They're coming in to grab the diapers. They're like, hey, you want to talk to someone? Talk about like how difficult parenting is. They do a parenting intervention in the moment. They don't have to jump through hoops to get really good, efficacious interventions. And this is how, like, my vision is for us to be able to deliver efficacious interventions as we think about CBT for mental health and parenting interventions in settings that are very comfortable for people to get in, that is like reduce stigma, that is very easy to get engaged and stay engaged. So really like thinking about these things is that we also, as a psychologist, as a researcher, we have to reinvent mental health to better meet the needs of the community. It no longer can be a 20 session in person, 50 minutes for you to drive to an hour or like take 20 buses. It has to be very creative, but also blends good data on the outcomes. We can't just do anything. It has to be efficacious so we get more bang for our buck.
I'd like to, yeah, clap that up, clap that up. I'd like to just add one more thing. I feel like in this room right now, we've been talking about a lot of what solutions could look like and things that we know are maybe working in one setting or at one hospital, health center, et cetera. But when we see legislators and we see elected officials, oftentimes solutions do come from the ground up. So they're in office, they have a leadership position, they often have ideas of their own. But it's important for when we do say, oh, this works, this should be everywhere, that we organize, we mobilize, and we inform people in power. This is what we want to see, and hold them accountable to that. Because that way we can have these wonderful services in so many places. We can get funding for the types of services we want to see. And sometimes that's a longer process. But if the ideas never make it to folks in power, if the ideas stay stuck in maybe the community level and they're not making it to those rooms, then it's like, oh, well, we wish we could do something about this. They're in the room saying, I think we have the solution. What we're doing is working or it's not working, but we don't know what to do. And sometimes the solution's right here in this room. So I just want to remind folks that we can use policy and legislation as a tool to spread what we think is not only efficacious, but what we know is community driven and what we know validates the lived experience that so many of us have.
This is powerful. I'm really thankful for the panelists and your thoughtful responses. One more question from the in-room, and then we'll switch to some online, and then we'll see how much time we have left.
Good morning. I want to make certain it wasn't afternoon yet. Hi, I'm Georgia Simpson, unaffiliated at the moment, but way too many years doing the work. Thank you all. And Magdalene, thank you for your story, sharing that. That's what makes what we do real. And hopefully, I hope at least 5 people come up to you after this and hand you their card. Okay. But I have a question. I do have a question. I'm sorry. I remember your instruction.
Good.
You know, again, having done this, everything from, I don't do direct service. I did a lot of program design and development work. I worked at Harvard Street for a while. And then went all the way to the federal level. We talk about policy, and the question I have is, how do we, and this has always been a question for me, that intermediary role, like how do we get from grassroots to that policy? What is the strategy to literally get the information from where we know the experts are, which are the grassroots, which are people on the ground, people with the lived experience, into those policy discussions rooms, and then more importantly, into the documents that get written? There is always a disconnect. Like I said, I've been doing it a long time. And that disconnect, I'm hearing the persistence of this disconnect. How do we strategically make that happen, close that gap?
That's an excellent question. And I feel like the way our systems are designed, they're not easy to navigate, even for people who spend a lot of times in a classroom, like learning how. So I will say that. In the work that I do currently, I do see how people, community members who have ideas, those do end up getting passed into some type of law or ordinance. Now, the thing about the legislative cycle, it takes a really long time. So let's say we discovered a problem today, getting that addressed often takes years and years and years. 5 to 7 years, 10 years, because folks have to really coalesce around what a problem is, decide that we agree on a problem, and then get a group of folks together to say this is a viable solution, and then mobilize around that solution. There's a coalition that I'm a part of as part of my job that they were trying to pass wage equity and wage transparency. And they had been working on this for 10 whole years. They just wanted you to be able to have, when you apply for a job, it says this is how much the job is going to pay you. And so that was what they came together around. Organizations across sectors, community members, schools, a whole bunch of different folks, small business, et cetera, came together, and they would go to the legislator, they would go to hearings, they would testify, they would go online, they would do a multitude of strategies to raise awareness that they want wage transparency. And one legislative cycle, the bill dies. The next one, it got a hearing. The next one, it got multiple hearings. And it went on this journey over a period of years. And it was finally signed into law last year. And I think went into effect earlier this year, or is about to go into effect right now. So those are more longer term solutions when we think about what's something that can change. But it's about getting folks together. And I'm also a registered lobbyist. So I lobby people, and lobbying is a very dirty word. I don't like it. Notice I didn't tell y'all, hey, I'm a lobbyist, because I lobby for small and micro businesses. I lobby for small Black businesses to get resources. So lobbyists, it's easier for us to get in rooms and translate what we're hearing in a nonprofit space, when we're hearing in a healthcare space, what we're hearing in a community-oriented space, and bring those people to decision makers. So I do see myself as kind of like a bridge in that sense. So it's really hard work. I'm not saying it's easy, but it's still worth doing. And those solutions we find are often meeting people's needs and codifying something that, otherwise this is good over here, it's not great over here. We need some form of standardization for things that are good, if that makes sense to folks.
Any other?
Okay, we're now going to pass to some questions that came in over the online portion. Thank you.
All right. These are the online questions. So, could panelists comment on specific policy levers, economic or others, that are most promising in improving child family level social determinants of mental health?
You're so cute.
I'm not the only one that's allowed to have policy ideas. I know you all have policy ideas as well. Okay, so I did take some notes. I wrote down some things. So when I talked earlier about social determinants of health screening and making sure it's beneficial to meeting actual needs, when I was at DMIC as a patient advocate, oftentimes we would say, okay, here's help steps. And that was it. And I don't think that's the most effective thing that we could be doing, because we can say, here's a list of providers, but if folks can't access them, if it's not affordable, if there's like what we talked about earlier with a wait list, folks aren't able to access care. So that's just one example that we could think about. I also was looking at this concept of when we see prescription, we prescribe going outside. We prescribe nature as a prescription, because oftentimes folks need to go outside, and it's something that can benefit our mental health, but also some people don't live in a safe neighborhood to go outside. So how are we not only using that as a strategy to address mental health and wellness, but also making sure that folks have a place to go? There's folks who do amazing work to bring people to go for walks, to go in the woods, to be in nature, and to ensure that people of color have access to those things. There's something called the adventure gap, and it's basically saying how white people are able to take advantage of outside and natural resources. But they're 60-something% of the country, they're outside more than 70% of the time. But Black people are 13% of the country, and they're outside only about 10% of the time. So there's this big gap in who's able to go outside and spend time and be in nature. And I think that's one strategy that we could utilize that is free oftentimes, that folks can take advantage of. Also, I would like to list that So when we think about mental health solutions on an institutional level, it's really important that we look at having some type of impact rubric. We talk all the time about how do we make sure things are racially equitable, and we have a racial equity rubric, a racial equity impact rubric, but to decide on one policy or another, we can have a mental health impact rubric, and we can use that for policy decisions. Should we do policy A or policy B? We could also use that around programmatic decisions. And sometimes it's not only important to just have these tools, but to actually utilize them. It's great to say, oh, I have this rubric, it helps me make decisions. But, oh, actually, I just like this policy more, so we're going to go with it. I think it's really important for us to really rely on the tools that we have and think about what are the variables, really nerdy, what are the variables that matter most to us? Is this equitable? Is this going to benefit people of color? Is it accessible? Is it affordable? Is there political will to do this? Is this going to be a burden on a certain group? Do we have staff capacity to maintain this? Is this going to be sustainable? These are all things we could utilize when we're thinking about what type of mental health policies we want to support and what will be best for children and young adults. Because I can say right now, I did have a list, but it doesn't feel useful for me to share the list. I think what's most useful is to prescribe solutions to different settings. So the folks who are in that setting, the folks who are working with those young people, think about place-based solutions and design what's going to work for that individual group, because otherwise it's just a list of strategies and hard to implement.
I think that two things come to mind. Massachusetts probably has some of the nation's like best parental leave policies. That's one thing that comes to mind. But I think it could be a lot better. And also with our research with people living with mental illness, they do talk a lot about their a work gap, employment gaps because of their mental health needs. And I think there is an opportunity for us to provide more supports around having breaks if they need to go. I think there's like some at the policy level, but there is quite limited. And also like when children get sick or there's a mental health crisis in the family where the parent maybe have to take some time off, I think there's also a lot of opportunities for us to be able to protect their jobs and employment when those things happen.
Thank you so much. I just wanted to highlight, I was just looking it up, there is a bill called Nature is Medicine. Licensed professionals can prescribe outdoor time. It's Bill S791, and it brings mental health and medical treatment and social rehab together with being able to prescribe outdoor time. Also, you should all look up social prescription, which is also a wonderful way to think about doctors prescribing. The ability to go to cultural, nature, other ways to address your health in addition to whatever medical services there are. So let's keep thinking and hear the next question.
Here's the next question from our online audience about integrating the immigration journey into our understanding of the social determinants of health so that our policies, data, and care models reflect the full continuum of the experience. So really thinking about that whole journey, how can we do this integration from pre-migration, resettlement, and integration?
Again, as somebody who works in a health center, I can tell you, we serve a lot of immigrants, immigrant population, and the journey is very stressful. And the times we're in actually now is not even making things a lot even easier. So all these things leads to major mental health. But the worst part of it now is even the fact that most of you know, right, by the end of this year, a lot of people are going to probably lose their insurance, right? Mass health standard will cease to be effective for a lot of immigrant population. So these are real life events that are happening. So we're seeing a lot of people with mental health illness now because of the fear of deportation, arrest and stuff like that, stop coming to receive services in our health center. we put up signs everywhere, like trying to help people to just make them feel secure, but we can't even assure that security to folks because we know, and they've told us that they can come in and arrest somebody inside the health center. So what does it do to the mind of immigrants? Fear, stress, anxiety, depression that is not treated because they're also scared. I talked about telehealth, but even at some point, we're in a meeting maybe a couple of weeks ago, we were trying to, and I was thankful to Mike and all the stuff that he's doing. I was trying to advocate eventually, if this passes maybe by next year, how do we still provide mental health services to everybody else, right? Without the justification that you have to provide, is it medically necessary? Who does that determination? Somebody has to say, oh yeah, mental health is medically necessary, okay, let's approve it. So these are the policies that we need to change, please. Whoever is involved in these kind of policies and stuff, we have to make sure if we are really serious about addressing mental health, right? We have to be serious about, okay, these are medically necessary for the insurance companies to pay. Just like public health doesn't have boundaries, right? Mental health also doesn't have boundaries. It doesn't care who you are, doesn't care whether you're documented or immigrants or naturalized or born citizen. So people are scared. People are beginning to stay away from receiving services, and it's not even getting better. Thank you.
Oh, hi. I met somebody outside of the street, and he's disabled. He's a 21-year-old, and I offer him help. He's homeless. He's from Honduras. He finished his 10 years. He got burned in Shriners Hospital, and I took him to Bridge Over Troubled Waters because he was nervous of like he said, ice, and he was sleeping, and he's been sleeping outside. He sleeps outside Charlestown, and I give him food and I give him clothing. And like he said, it's really sad. But I offer myself to take him to Bridge Over Troubled Water. I help him find apply for myself, and besides my son, I just want to help other people too, because it's good to be human and be there for them.
Another online audience question. Actually, we have a few questions talking about how to address the needs of folks with severe mental health illnesses, and kind of thinking about what are ways other than guardianship to help those who have severe mental health issues.
I mean, first of all, it has to be diagnosed. Mental health is very, very wide, like you all know. One, go to a health center. I will advocate for a health center. Go to a hospital, but see a therapist basically, right? But it starts with major diagnosis. At least if you have this, if you have it diagnosed, right? Now you know exactly what you're treating. If there's a need for medication to be prescribed, let them take it, right? But mental health is not also something that you can deal with like in 1 month, basically. Some mental health conditions are lifelong. If you have schizophrenia, for example, It might be a lifelong stuff to deal with. So I'll basically say what? Diagnosis, in treatment, and ongoing treatment. Do also assessment of social determinants of health. There could be some other underlying issues as well too that need to be addressed. So for someone to get their life together.
I think that's great. I think also adding to that, thinking about what are the rights and protections for caregivers and ensuring that, you can get funds for caregiving. You can get funds for resources for caregivers. That's another policy I think that should be pursued more deeply so that folks who are oftentimes caregiving without a break are maybe able to get a support a couple times a week or are able to get funding to be able to do so in a way that allows them to step away from work when they need to. So I'm always thinking about what could we do to support caregivers, whether they're caring for people with severe mental illness, whether they're caring for children, whether they're caring for elders. I think it's something we all need to look into more deeply.
Thank you all so much. Oh, I just stepped on someone's foot. So sorry. I wanted to see if there's any closeout thoughts from the panelists or the moderator before we switch over to the next panel, which will be about housing and mental health. So we can really dig in to a local issue and see how we can address that. But let me turn it back over to the panelists, the moderator.
Samara, I will always take an opportunity to talk. Okay. The last thing I'll share is just, I think when we think about solutions and policy, there's so many different, there's big P policy, there's little p policy. There's things that can happen on your local level. There's things that should happen at the state level. Right now, I think in our country, we're witnessing that things are happening on the federal level that seem very out of control, very out of control. There's things that we can do at our state level to try and bolster what we have here that we think is working. And so I know folks might see what's happening at the federal level and say, all of this is going to get destroyed. But at our state level and at our city level, there are people working to defend wins that we've had here in Massachusetts and maintain those. And there's still new ideas being generated of how we can do that, and folks who are working on that every day. So if you have ideas, if you have solutions, now is, like I said, we need a groundswell to inform our decision makers at the local and the state level. They actually have a lot more power than we think they do if you want to look at the weight of the federal government versus, the rights and the power of states. So I want folks to keep that in mind and don't feel fully doom and gloom. There's a lot that we could do locally, and I'm happy to talk with folks about what that could look like.
The last thing I would just say is let's take a look at how to empower the minority population in terms of economic empowerment. So creating jobs from the grassroots. I mean, jobs, entry-level jobs, right? Please keep people out of prison. Please, because it takes so much to get someone reintegrated back into the society again once they come out, because they go in there, they're stripped of everything else. And then what happens? Now they come back, you're stressing for with housing, you're stressing to get a job. Now, depending on what crime you're locked up for, you may be able to get a job again or not get a job again, right? And then you're living in a very stressful environment as well too. Green spaces, right? You talked about it, green spaces, where people can actually feel free to walk around. And I'll give you guys a very quick story, right? A colleague of mine, her daughter, they live in Marapan, and then her daughter went over to sleep over in Needham, right? One of her friends. And she was shocked how she and her friend were able to just walk around the streets, freely and easily, without their mom looking for them, and came back safely. So she was like, I came back and asked her mom, why can't we move around like that in Manapan, right? You all know why. Yeah. Why do we have, once you leave Milton and enter into Manapan, your anxiety level goes up. You see all the stores locked up. So basically what I'm trying to say, how do we reduce those level of crime in such a way that people don't go through stress when in that environment? Once you walk in there, you can feel your tension going up. Your anxiety goes up. Yeah. You start thinking about, am I safe? All these things lead to serious mental health issues that need to be addressed. Give a space where people, young folks, can actually go and relax without any fear. My hope one day is to have a space where people can just come in, drink a coffee, stay, while away some time without thinking of crime, right? And then maybe somebody, a case manager, can help them to navigate their life. Ask them, what do you need? What can we help you with? And then guide them to become role models to get their life back, So maybe someday that will happen. Thank you.
Did you want to? Okay, I just wanted to give the opportunity. Well, I want to thank all of you. As a moderator, we're in a privileged position because, well, we don't have to answer any of the questions, but mostly because we're representing the audience. We get to be in the audience as well, and I want to thank all of you for what you've shared today. Certainly, I have learned a lot. Standing here and listening to not just your stories and your experiences, but also even the questions that get my mind thinking about what we could or should be doing over at the city, and in particular in the area of economic development. I just want to say, because a lot of our attention and focus has been on the experiences of Black and Brown communities here in the city of Boston, but I do just need to say that this is not just a Black and Brown issue. Systemic racism, these insecurities, these inequalities are affecting every single person. And in the work that we're doing for economic development, there's two pieces of information I always share out, and Beckma was the first to push this forward. The first is that there was a report published by Citigroup in 2020 that showed that because of America's warm embrace of systemic racism, between the years 2000 and 2020, the nation had lost out on $16 trillion of wealth just because of the gaps between Black and white households. The Massachusetts Taxpayer Foundation, which is not a liberal organization, but they did a similar study in 2021 that showed that if we were to close gaps in education and housing and small business development between Black and white households alone, we'd add $25 billion to the state economy over the next 5 years. Okay, so this is not hurting Black and Brown people alone. This is lost wealth and lost opportunity across all of our communities. And when when Dr. Curry was giving his remarks, that close the pump piece was very interesting to me, because a lot of times we are not addressing the root causes at the policy level, at the city, or really in government in general. It's usually being responsive to a popular cause or what someone is championing, but doesn't really get to the issue. And it reminded me of this Ethiopian proverb that says, "Do not look where you fell, but where you slipped." And so I think at the state level, working with our partners in community, the mental health piece seems to be one of the places where we have slipped, that we need to address head on. And so I appreciate what everyone has brought up today. We certainly have not incorporated mental health in our strategies in regards to small business development, in workforce development. And after today, this is the first thing I'm going to be bringing up with Trent and others on our team on how we're addressing some of these insecurities in our community. So again, I want to thank you all. I'll leave with a proverb that says that if you want 1 year of prosperity, grow grain. If you want 10 years of prosperity, grow trees. But if you want 100 years of prosperity, grow people. And it's because of the work that all of you are doing in community, certainly the leadership displayed by our panelists today, that we are ensuring the prosperity of our city and our Commonwealth because of all the work that you all are doing to grow people. So I want to say on behalf of myself and our team and on behalf of Mayor Wu, thank you all for what you've been doing, and thank you for this conversation.
What do you say? I know people think, no, we're going to keep going. We've managed to get close to the time. We closed the gap a little, so doing good. Oh, you have a surprise inside. Heart. Good thinking. Right. I don't know Samara's clap thing. Okay. Samara.
Yeah, works. We should have to get all the panelist stuff. That's Sheila.
Sheila. Oh, yes.
Yes.
Oh, no. I'm gonna say that there.
Thank you, everyone. I know it's so tempting to schmooze, but we're going to ask you to sit back down. We turn the heat up. Come on back to your seats. If you can hear my voice, clap once. If you can hear my voice, clap twice. Thank you.
I'm going to steal this. I'm going to learn the clapping thing. So again, I want to thank everybody for that amazing first panel, for the wonderful dialogue, for the engaging questions. I know we don't have a lot of break built in, but we're going to get going because we have a second wonderful panel. And so I'm pleased to introduce our moderator and panelists for the next discussion on housing instability and mental health. Our moderator is Sheila Dillon, Chief of Housing and the Director of the Mayor's Office of Housing. So please join me in welcoming her and our distinguished panelists, again, whose bios you can find in your virtual brochure. So thank you so much.
Thank you. Is it still more? It's still morning. Good morning. It's great to be here. Having worked in housing and supportive housing in Boston for now decades on housing issues, community development, it's not lost on this crowd because probably many of you are practitioners and mental health experts. And so you know the connections between housing and mental health. And nothing could be more evident day in, day out that if you're going to have health, you're going to have strong mental health, you need stable housing. So hoping to get into that with our panelists today. Like was mentioned, I'm Sheila Dillon, and I'm really happy to be here. And I'm very happy to be here too, because for a while, I'd say, I don't know, 4 or 5 years ago, there was a lot of emphasis on the connections between health and housing. And then as things go forward, right? Sometimes things are really prominent for a while and then they fade. I think that emphasis has faded over the last several years. So I'm really happy to be here today and learn and hear, and also make that connection again in my own mind on how important housing is. So my job is to ask this esteemed panel some questions and for their insights on various topics. And I am hoping that we can move this along and then get back this conference back on schedule. So I'm going to start, if it's okay, when I asked you the question, if you could just introduce yourself again, just for the group gathered. So I'm going to start off with Toy, if that's okay. And my question is this: how does housing instability increase and magnify poor mental health, especially in communities experiencing discrimination and racism? Big question. Mm-mm.
Hello.
Yeah.
Hi, everyone. My name is Toy Burton, and I'm the founder and executive director of Didi's Cry Suicide Prevention and Family Support. I'm also the founder and executive director of the Roxbury Unity Parade. So Didi's Cry is named after my sister. A lot of people think I started Didi's Cry because my sister Didi died in 1986 by suicide. I started Didi's Cry in 2017 after being on the websites of organizations that focused on suicide prevention. I became angry because I didn't see anyone who looked like me. And when I clicked to see where their events were happening, I was like, this isn't for someone who lives in Roxbury, Dorchester, or Mattapan. So I thought to myself, I'm going to create something that's for our people when the things happen in our neighborhood that our community needs suicide prevention. And I'm also a suicide attempt survivor, among a host of other surviving things. But to answer your question, and having dealt with housing instability before, but a lot of what we do with Didi's Cry is that I get a lot of phone calls from people. And recently, a lot of calls have been about housing and helping people find housing, helping people find shelters. And of course, I can hear the distress in their voice that not having housing is causing it. And the thing about housing too, so I'm going to speak on a particular person who called. So because that she was moving from house to house, not being able to get into a shelter, she couldn't get into a shelter because she was having issues in New Hampshire, and because that relationship in New Hampshire was harmful to her and her children, she came to Massachusetts. But because she didn't have a Massachusetts ID, she couldn't get into a shelter. So that's one layer of stress right there. Finding childcare for her kids. Her support system was in New Hampshire, so now she's trying to create a support system in Massachusetts to find childcare. Employment, you need employment for the childcare. So trying to find the employment, she did find the employment, but had to, maybe she worked there 3 weeks because of the childcare situation. So the people that she depended on for the childcare wasn't reliable enough to keep the job. And of course, she's constantly calling and crying because of the housing situation. Just staying with people, she's like hearing them talk about, her kids making noise. So you're not comfortable. You don't feel safe when you're hearing people complain. You feel like a burden. You feel like you're a failure to your children. Sometimes you feel like you're a failure in life, and all that just weighs on your mental health. So we know that one always affects the other, and
just being discriminated against, not even saying racial discrimination, but she was discriminated against because she didn't have a mass ID. So even though, no, the one thing she didn't know, because I was like, do you have a cell phone? I was like, is the bill in your name? I said, that right there is proof that you're in mass. If you have the cell phone and you're paying it in mass, that should be the proof. But all the hoops that people have to jump through just to receive the support that they need, just to make it through today, the day, is shameful.
Thank you. Thank you so much. And that story is certainly one, like, it's variations, of course, on a daily basis, but those stories are told again and again and again every single day of the week, that people are really, really struggling to put the pieces together to find housing. So thank you for being on the ground and doing that. George, have you seen mental health stigma cause housing instability? We know that bad housing can actually really create mental health issues, but we also know that it's very difficult when you have when you are labeled as having mental health issues to find housing.
Yeah, absolutely. Firstly, I want to thank Dr. Simone, Dr. Curry, and also Samara, Teresa for getting me to this panel, and Chief Dillon for your leadership and for that question. I think we definitely see mental health stigma show up in many ways relative to housing instability. And I'll start by saying that I'm no expert on housing. I'm no expert on mental health, but I'm an expert in my lived experience and now in my role as executive director at the Vietnamese American Initiative for Development, or VietAid. And I'll start by sort of mentioning a little bit my upbringing. And growing up, I moved around a total of probably 6 or 7 times growing up. My own mom and family, right, received a mobile Section 8 voucher. And, you know, growing up in a single family household, there's, you know, a bit of, say, a bit of shame, right, in constantly being um, in crowded houses with you know, packed boxes and bags and constantly moving around. And it doesn't really feel like you have a uh, sort of sure place to stay. Um, and how that sort of came out relative to mental health is, I mean, my mom faced her own mental health challenges, and I think it affected how each of me and my 3 siblings, or the 3 of us, me and my 2 siblings, sort of viewed ourselves relative to our classmates, relative to um, the world, um, right? And we didn't really feel that sort of pride in having friends and classmates over our own homes. Um, and so thinking about that, those cultural pieces of shame and embarrassment, especially in the Vietnamese and the API communities, um, you know, mental health is not really a subject that is talked about very often. Um, and it's something that, you know, you sort of overcome um, through hard work, resilience, focusing on the day to day that needs to get done. Um, and I think I see firsthand now in my work at VietAid, where 96% of our clients um, identify as Vietnamese, and the overwhelming majority are low income. But actually, within our housing developments, 85% of our tenants identify as Black and Latino. Um, there's a real sort of risk that is perceived um, for residents that have mental health issues, right? And where that comes to play is there's a real cost that comes with providing extra supports to folks with mental health. Um, and so when you're talking about folks who are sort of hesitant to seek supports from mental health providers, um, you know, they don't want to be labeled as somebody with mental health challenges, but in reality, folks with folks who do experience mental health come from all walks of life, and even those who are the most housing stable and in the most ideal situations, um, you know, do face these barriers. So when you're and those who are most housing unstable, um, roughly 2 out of 5 people in Massachusetts who experience homelessness experience serious mental health issues. So those two go hand in hand.
Thank you so much. And thank you for the work that you're doing at VA-Aid. I mean, building affordable housing, especially with support services, is certainly a key to making sure that we're meeting folks' needs in the city of Boston, including those that have mental health issues. As we plan on responses and what to do to really combat our housing issues and our health issues, we often look at data. We often want to know we've got finite resources. I shudder to think, and I hate to think about what's coming for many of us in this room as we deal with the federal government challenges. I can talk a little bit about those in a bit. So we're always looking at data. And Stephanie, I'm wondering if you could talk to us some about what kind of data should we be looking at, analyzing, gathering as we make policy decisions on solutions, including housing solutions.
Great. Hi, everybody. I'm Stephanie Edinger de Cuba. I'm a research associate professor at Boston University School of Public Health and School of Medicine. Also executive director of a group called Children's Health Watch. So yeah, I mean, I think the city's actually done a really great job of looking at mental health across neighborhoods and across populations, things like persistent sadness, some really serious outcomes like attempted suicide, lack of social connection. All these things are super important things to track, to look at by neighborhood and understand, where people struggling the most, the least, and what but not just to say, we found this, but to figure out then what's the root cause, what's the solution, what do we need to do in those neighborhoods, right? So I think all those measures are super important, thinking about mental health that way. But, I've really loved the conversation today because I think what we're getting to is thinking much more broadly about what mental health measures could be. For example, housing instability measures, eviction rates, that's mental health. Those are traumas, right? And so if we're talking about what do we need to do, those are some things. So I just wanted to talk briefly about a study that I think really underscores this point really well. It's not my work, so no credit I can take for this. But this is a terrific study, a recent study looking at trajectories of evictions by neighborhood over time. This is a study in Detroit, but basically looking at pregnant African-American women, looking at where they lived pre-conception and then where they lived during pregnancy, and tracking it over time, and looking at court level data about eviction filings and eviction judgments. And to summarize, and then they were looking at psychological distress, both sort of low, moderate, severe. And basically, the punchline to this study was that women who compared to women who always lived in a neighborhood where the eviction rates and the judgment rates were low, women who were in neighborhoods where either they'd gone from medium eviction filings and judgments to high eviction judgments and filings during pregnancy, or kind of stayed in like medium to medium. Basically, that those, that there were relatively high rates in those neighborhoods. Those women were 2 to 4 times more likely to be experiencing severe psychological distress, and in particularly people who had moved from low eviction filings and judgments to high areas, they were more likely to be 4 times more likely to be experiencing moderate psychological distress. So, and these were women who weren't necessarily being evicted themselves, right? So the point is, being in a neighborhood where there's that kind of instability, where neighbors around you are experiencing this trauma, is a trauma, right? It is affecting your mental health to be in that kind of instability. It's, not rocket science, but I think like the numbers are really pretty striking. And I think we don't sort of recognize that the ripples from being in neighborhoods that are, well, we do in this room, we do, right? But in general, there's like, people don't really understand how this sort of chronic disinvestment in neighborhoods ripples out to people who maybe they're okay income wise, right? They might be doing fine income wise. They're not at risk for eviction, but they're knowing that their neighbors are going through that and seeing it around them. I think you could make the leap to what's going on with, ICE enforcement right now. Being around that, even if it's not happening to you, is incredibly destabilizing. It's hurting people's mental health. And so I think tracking that sort of thing by neighborhood is incredibly important. And Samara and I co-authored, along with some others, a commentary where we actually talked about, what are some of the implications of this eviction study, and really thinking again that vicarious trauma, it has to be paid attention to. That we don't, of course, we want to pay attention to severe mental health outcomes, absolutely, but thinking about sort of those under the surface, I'm just really not doing well, and so maybe struggling to hold down employment, or be fully focused at work, or be fully there for my kids. Like that kind of mental distress is also incredibly important and needs tracking and attention, because that is what later can turn into severe mental distress, and or just like reduce people's quality of life. Getting back to the idea of our weathering, right? And housing is so fundamental to us feeling rooted and safe in our lives. If you don't have stable housing, it's so hard to work on any of the other things. And I think that comes out over and over in research my team has done through Children's Health Watch. We looked at like the expanded child tax credit, for example. What were the big findings there? Parents' mental health improved. And when we did a qualitative study, they talked about how they were able to sort of like lift their eyes to the horizon, stop being rooted in how I'm going to get food on the table, how I'm going to keep the roof over my head, how I'm going to do this, and start thinking about, how do I engage with my child? How do we spend time together? How do I help them advance, right? They could like start thinking forward. You can't think forward. Everybody's been saying this. I'm not saying something new, that you can't think forward in your life if you're constantly scrabbling for the moment. So I think the more we can think about things like guaranteed income and tax credits and housing supports and wraparound housing supports and, stabilizing neighborhoods and investing in neighborhoods, to all people's points before, I think that's just vitally important. And we can talk more about some of the details of that later.
Yeah, thank you so much. And when you were speaking, I was thinking about last year's data, because I was looking at it a couple of days ago. So last year there were 1,500 executions. Those aren't filings. And if you're being evicted, the first, the process is the landlord files, and then the judge gives you an execution, or they work something out. But even the filings, which are about 5,000 a year, just are incredibly stressful for families. And most of these are families in lower income neighborhoods. But 1,500 families, mostly families, received executions. They had to leave their apartments. And what we do at the Mayor's Office of Housing is we run around and we try to get back rent paid, or we try to get someone a pro bono attorney, or we try to get them out of there, and a bus ticket to their sister, and whatever. But what we never do, and I'm sort of, as you were talking, I was thinking about this, we never have our colleagues at public health or the nonprofits call up and say, hey, you've been through an awful lot. Are you okay? So it would be a very, very decent step to like make sure that the family is okay because they had been through a very, very traumatic event. So, Thaddeus, with all that you've heard, right? How can public health, financial interventions, housing sectors work together to improve and create equitable mental health outcomes? Small question, small answer.
Yeah, so I'm Thaddeus. I'm old. I've done a lot, so I'm not going to give you my 15 titles. But I think the one thing that we need more of, no matter what happens, is more of what Toy did. She saw a problem. She had the courage to step out. She was vulnerable enough to talk about her sister, talk about herself, take action, and create something for all of us to be able to benefit from. So I just really, again, Toy, want to say thank you for your courage and your vulnerability and for doing what you did. So, like, the one thing I got to say this because I don't have on the suit and the tie and dress shoes. I'm not representing mass housing today, right? So I work at mass housing, and if I'm representing them, I got to have a suit, tie, and shoes on. So when you go back, if you see anybody from mass housing, say Thaddeus said he's not representing mass housing today. But I'm like John. As a kid, I moved 10 times. My sisters and I didn't graduate from the same high school. We moved so much, right? Single mom and, home full of domestic violence and a lot of other sets of issues that created certain insecurities. And until we moved into public housing, where I didn't really know what public housing was the first time I actually felt safe. And I think that was a piece that I knew I had a home that I was going to be able to stay in because my mom said so, right? And she had never said so before. But when I started to think about like mental health and some of the other issues, I started and just health in general, I also started to think about my mom. And when I think about my mom, she passed a year and a half ago, but I had to write them down: COPD, right? Stage 4 kidneys, diabetes, congestive heart failure, and then vascular dementia. And, when you started to think about the mental health component, I knew something was wrong when I missed my flight flying home for Thanksgiving. She had called me and said, hey, look, I really need you to come home for Thanksgiving. I just want to hang out. I missed my flight, so I drove home. I got there Thanksgiving morning. She's a great cook because that's what she's done all of her life. And I'm not really smelling anything. It's smelling like stuff is burnt. And I'm like, Mom, what did you cook? She's like, oh, the biscuits and everything else is in the oven. And when I went and looked in the oven, it was on low, but she never took the plastic off the turkey or anything else. Everything was just burnt. Right. And so at that point, I knew that there was some issues, and we went to do what we needed to do. And sure enough, 3 weeks later, she was cooking some bacon, and it's spilled over. The grease spilled over in the oven, and the whole house became dusty and full of soot. Luckily, we had insurance and everything else, but we realized she could no longer live by herself. And most of us were gone. And so we ended up having to put her in assisted living. And, it went from $1,500 a month to $15,000 a month. And I started to wonder and think about, like, what are families that can't adapt to that? How are they doing? How are they keeping their kids? I'm calling her kids because at that point she had become that kid of the family, right? It's twice a child, once an adult. And so one of the programs that I looked at that I used to oversee was at Mass Housing was the tenant prevention or preservation program. It's called TPP. I don't know how many of you here know about TPP. Anybody here know about TPP? A couple of different folks. Well, TPP, because I'm looking at all these sad faces. I wanted to give y'all some success stories, right? Something that's working in the state. And maybe when we start to think about putting additional money into something that's actually working. So it's a statewide collaborative among housing court, behavioral health providers, and community organizations to prevent eviction when health or disability issues put housing at risk. Basically, they're in housing court working with a lot of different folks. And two examples that I asked one of my colleagues about. And the first example was an example that was pretty close to my mom. It was an individual that had some of those sets of issues, but it had a therapist for the past 10 years. The therapist retired, and that person's depression and everything else went down. So they started not taking care of the house. They started not paying their bills, all of these other issues, and ended up in court for eviction. TPP is an intervention and sort of stepped in and helped, got them a new counselor, which everything improves and kept them from actually got them on meds and other pieces and kept them from being evicted. The other example is a person that was facing sets of issues around their mental health because of cleanliness and all of these other issues in the housing, hoarding and other issues, and were about to be evicted. And TPP was actually able to come in and work with them, get them counseling, address their hoarding, get the place clean, actually get them new furniture and prevent the eviction, and now actually has them on schedule and working very well and is still housed. And the first person, what I failed to mention, had been in that housing unit or in that development for 18 years. And after 18 years, about to be evicted because their therapist retired. And so when you start to think about those particular sets of issues, and the lights went out, so maybe that's my 1 minute that you got over there. So, but the other thing I really want to say about like TPP, some of the data, I knew I only had a couple of minutes. The quick data, last year in the state, they served over 800 households. 68% had behavioral health conditions, and they achieved a 90% success rate of preventing homelessness. And I think that's an amazing number that you have 800 cases, 68% that were really behavioral health issues, 90-some% that were low or very low income, and that they had a 90% success rate of maintaining it. And it proves that when you take housing, health, and community organizations working together, even in a court system that's unjust most of the time, that you do have solutions and you can actually succeed.
Thank you. Thank you. That is positive. Thanks. Give it up. So I'd like to open it up now if I could. Yeah, great. We've got a mic. And would like to, is that okay? Yeah. Go ahead. Oh, no, I'd like to hear what you've experiencing, if you have suggestions for the panel or for me as Chief of Housing for the city, or just questions for us. Thank you.
Yeah, so we're going to do 15 minutes of Q&A in the room, and then we'll read questions online just like we did last time. Right.
Thank you so much. I hope my question's clear. I've been trying to figure out how to formulate it, but how do we as advocates navigate the inherent violence that comes with a lot of these resources and systems? I'm thinking DCF getting called in, the police getting called in, or other organizations, and how do we as advocates try to avoid that mandatory reporter violence, tearing families apart part, while also engaging with the resources that have money, which are housing, DCF, DPH, the schools. Not sure what exactly the question is, but do you have any suggestions on how we can sort of start to remove some of that violence so that we can have people engage with services in a way that's not putting them at risk?
Yeah. Please.
You go.
I just want to say, I have no idea, so I'm just going to be quiet. but I thought it was a great question. I don't truly understand it, so I'm hoping that somebody on the panel can sort of clarify it for me.
I'm no DCF policy expert, but I know a little bit. So I'll talk about the little bit that I know. I do think the sort of, and I think there are good people at DCF trying to do the right thing, right? The intention piece of it is really important, of evaluating not just whatever it is that like caused that report to be filed, but looking at perhaps there are interventions like you were just talking about, like this is a solvable thing, that like maybe this bad thing happened, but with the right wraparound supports, we could get things back on track. And I do think that is in theory what is supposed to happen, but it often comes in with such a slam and a bang that it is really traumatic and violent for people. In fact, it makes me think of this term that we kind of touched on a little bit today. We talked about structural violence, but you can also think about policy violence, right? Like a policy that is, actually actively doing harm. And I know this is not a housing response to what you're saying, but I think, we can get creative like this. It was started with Boston Medical Center and has since spread to other hospitals. It used to be required that a 51A, a DCF filing was supposed to be filed every time a mother in labor turned up who tested positive for substance use. And they changed the policy and said, we are not going to file a 51A unless we have a safety concern. So for example, women were afraid of having a 51A filed, and they didn't want to come into labor and delivery because they were in substance use recovery and they were taking methadone or something else like that would make them come up as testing positive. And so they were going off their methadone in order to then be able to give, just like insane, right? So, some like creative thinking about what are the mechanisms that are actually doing the opposite of what we want to do. We want to keep kids together with their families. We want to support families. But if we're causing people to be afraid that they're going to be ripped apart and therefore go out of treatment, that is not serving anyone. And so if there is no other safety concern, and there now there was a bill that I believe has been passed to make it sort of actual law in Massachusetts that this is the approach. And they had like a dramatic decline in DCF reports being filed on pregnant and delivering mothers because of this. And instead, supportive services being deployed to help moms through that. It's, obviously anyone who's ever had a child knows it's a massive transition, right? To help people through that transition and stay on track during that transition, or if they're not already in recovery, getting them into recovery. So I think, anyway, to your point, I think it requires some creative conversation, some cross-sector conversation, and I have a friend who's a social worker in a NICU, and for her, it was such a relief because she felt forced to file these reports when she knew that wasn't the right course of action, right? So anyway, I think we can think through those mechanisms better and make some better choices.
Yes, very good question. I think we have to look at the mandate and reporting part. I used to be a preschool teacher, so I do know about mandate and reporting, but I also know a family that we supported who the child died by suicide, and the mother said that she had suicidal thoughts, but she never told anyone in fear that her children would get taken. So until we remove that fear piece so people can seek for the help that they need without the fear that their children will be taken or their jobs will be taken or even their housing taken, because I have received calls and they did, even though they had suicidal thoughts, they didn't want to join the group thinking that that would be on their record. But I'm like, no, Dee Dee's cry, I'm not a mandated reporter. This is peer-led, and you don't have to have that fear. But for them to receive medical treatment, we need to find a way to lift some barriers so people would not be fearful to seek help.
Do you want to add something?
Yeah, I'll add something really quick to what my fellow panelists have said. But I think to combat this sort of violence, that marginalized families already face, I think we really need to evaluate the lens through which we're viewing the home, right? I mean, broken homes, unstable homes are going to be homes with a single parent, right, are going to be viewed more unfavorably. And so we need to be able to provide a level of anti-bias training to folks that do come in, whether that's DCF or a social worker or another provider, right? And we need to train our providers and encourage more providers of color with language competencies, with cultural competencies, to be able to take on some difficult cases and make those judgments, relative to their experiences and their backgrounds that may not need to be elevated to, DCF or worst case scenario foster care or some really sort of interventionary measures.
So
Yeah. So I agree with John, because when you said violence, I took that in a whole different way of thinking. And so I think those that are trying to do this work, especially in housing or other places, need to become more familiar with the language and really what it means and what you're saying by it. Because I didn't want to sit here and act like I knew what you were saying, right? Because I think that does a disservice to me and to others that are trying to understand the work. And so I feel like what you just said is needed more, and I'm definitely going to bring that back to our team to be able to, like, do we really understand the questions that are being asked of us,
Great.
so that we can actually have real solutions to some of these problems.
Thanks so much.
So I'm going to actually take the prerogative of holding a mic. I've been with one thing before we go to the next question, because I'm just really inspired by the creativity and innovation that you are all talking about. And it made me think of another example that Stephanie is a part of, and Professor Danielle Crooks in the back. And it's just so relevant to what you're talking about is what happens when people start interacting with the judicial system. And I just want to share that another creative approach is that a group of us here and with the law school have been training judges in the social determinant of mental health for about 4 years. And we've trained about 1,700 judges nationwide. But one of the first groups we trained were all the housing court judges in Massachusetts. And I was just so excited and inspired as you were talking, because I hadn't really thought through all of the impacts that you're describing. And it got me even sort of more excited about that work. And thanks, Stephanie, for all the ways you've helped that. So with that, I just want to open up for another question. Probably have two people.
Thank you. Hi, my name is Kate Alicante, and I work at the Mass Association for Mental Health. Thank you to all of you for sharing your experience. I'm worried. I think a lot of people are worried that, maybe it's always been like this, but it feels a lot now that being homeless or having a mental health condition is being criminalized right now, and it feels illegal to be in that place, and that we're heading to a place where the solution is institutionalizing people, or I don't know, we were talking sending people to jail, and I'm nervous that that's like where the narrative is heading, and that it's almost helping people to send them to jail or institution because it's better than them being in the streets or being housing unstable. And I'm wondering, because you all come from different experience, whether it's individual storytelling or community organizing or using your data or programs, or even on the city level, just like what can we even do just to combat that narrative? Like, yes, there's policy solutions, and those feel under threat. Like housing first is, I guess, no longer a priority for SAMHSA. So just like on a very simple level, how can we like communicate and share with our communities that anyone in those experiences, they're not doing anything wrong, they're not doing anything that's illegal, and making sure they feel supported, and also making sure our neighbors know that they need help, they don't need to be arrested or sent to a place so that they're not seen.
I'll just respond, and then I'm going to hand this over. I too am very, very worried about the rhetoric in this country right now, and the general public. Right, I think once the federal government starts talking a certain way and takes certain actions, then the public starts to also adopt that language. And in Boston, and we have the lowest street homelessness counts in the country, which is a credit to many of you and a really strong network of nonprofits that have been building supportive housing for decades. And very, very proud of that work. It's great work. And we have lots of development right now. supportive housing, that so folks are coming off the street and getting all the supports they need to live independently. And you're right, the federal government right now is very anti-housing first, and they actually see people living on the street with housing barriers, issues, substance use disorders. They're seeing those folks as needing to be jailed or institutionalized, et cetera. So it's completely different than how Boston has been operating for many, many, many decades. And we're waiting for the continuum of care NOFA to come out. Like, it's just jargon, but it's all of our homeless money coming from the federal government. It's going to drop any day now. And we're hearing that they're going to allow 30% of those funds that we get every single year, like clockwork. We have to apply, we have to perform, that they're only going to allow 30% for permanent supportive housing. We fund well over 2,000 households that have got, that are usually chronically homeless and have some kind of disabling condition, sometimes mental health issues or substance use disorders. And if this really comes to be and we can't fight it in the courts, I'm very, very worried about seeing a very large uptick on our streets. I don't want to be depressing today, but I just want all of you to know that this is taking place right now. So I think Boston has had a good response. There certainly is different approaches being taken at MassCast right now that you're probably very aware of. We are meeting weekly about the people that are there repeatedly and working as a group to get them the services that they need. It's much more organized than it has been. So I think that Boston generally, not every day, sometimes we make mistakes, but generally Boston is doing the right thing. But I'm very worried about the repercussions of what the federal government is doing and how it's going to impact us. Not to be depressing. Any good messages down there?
I mean, I don't know that I have a magic bullet for that, but I do think, the federal situation is incredibly difficult. Basically, the opposite of any research or lived experience would tell you, like, whatever the right thing is to do, we're going to do the opposite. That's pretty much where we are right now. That said, I do think, here in the state, we have opportunities to do things better. I have not given up hope at the federal level. A lot of the work that my team and I do is federal advocacy. And I think part of it is helping them understand that actually these issues affect all of us. Like, you think putting a person experiencing homelessness in an institution doesn't affect you. You put them out of sight, out of mind, but you're paying for that. Like, sometimes sorry to be crass, but sometimes the economic argument is really powerful. Like, we are paying a lot of money for that. We could be spending our money a whole lot more wisely and have better outcomes for everyone, more resources for your community, person who's in a, wealthier community that doesn't think about these things. But guess what? Like, here's how it might impact your community. And I think that has been a successful argument, especially talking to folks on the more conservative side of the aisle. We've done that thinking about food insecurity, calculating the avoidable healthcare, workforce, and education costs of food insecurity. My team looked at that as $227 billion a year that we spend remediating things that we could avoid if we just made sure everybody had enough healthy food. And same thing with housing. This research that was a few years ago, but we looked at just for mothers and children. So this is not even including men, but for mothers and children, we're spending $111 billion over 10 years to deal with housing instability when we could. So that's like moving multiple times, being behind on rent, all the things that folks have talked about, experiencing homelessness. In healthcare costs, in special education costs that we could be spending to provide permanent supportive housing, that we could be investing in affordable housing, all those sorts of things, right? So we are spending money very poorly, and sometimes that's the narrative that needs to be given, and it's sometimes feels like the wrong one because you want to talk about the impact on people, but that is the impact on people, right? It's also about the dollars. So not a perfect solution, but I do think that is some of the messaging that we have to keep bringing forward.
Yeah, I think I live in a town that when you pick up the paper and you look at who's been arrested this week, all of it has homeless, 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 homeless. I didn't really pay much attention until I was walking to the gym one morning at 4 a.m. and I got pulled over by the police because they thought I was homeless. Luckily, I had my ID and everything else, and and I could actually call the commissioner that morning and woke him up at 5 o'clock and asked, "Why are your police officers pulling me over while I'm walking to the gym?" Right? That you got two cruisers pulling up on me walking the sidewalk when the gym's 5 minutes from my house. But what I learned is that I needed to use my privilege to be able to, one, make a phone call to him at 5 in the morning and say, here's what's happening. Two, that I needed to start actually doing more work in the homeless shelters so that I had a better understanding of how I could use my privilege. And then being able to do that, I started bringing more friends to actually work in the shelters, and whether that's serving food or something else, and getting really educated about what the problem is and understanding what some of those issues are for those that are actually on the streets, going talking to them and working with other experts, not just going out on my own, but actually going and talking when the groups are going out, they're doing the counts, they're doing other pieces, being able to participate, and then being able to speak up at city councils, right? And having the other friends and others speak up at city council. So while I understand that the federal government is doing what they're doing, there's also things that we all in this room have a level of privilege that we should be able to enact and use to really deal with, whether you live in Boston, whether you live in, since we're on Zoom, I don't want to say my town because then I might get yelled at. But wherever we live, we've got to figure out if it's something that we really care about, that we went from the pity, sympathy, empathy to compassion, which is a verb, which means that we're actually doing something about it and not just talking about it. And so for me, that was how I'm addressing it and will continue to address it, which using my privilege within my town. Hopefully that will look at what's in the state and then be able to understand what's happening federally.
Great. Thank you. George, do you want
Yeah.
to add something?
I think what I heard was, and the question was, how do we make mental health challenges, mental health issues feel more normalized, right? And I think it just comes down to recognizing the link between mental health and physical safety, housing stability, just being okay, right? Feeling good and content and well. And that comes in various ways. And it doesn't have to be seeing somebody in an office and talking about your problems, right? I think super high functioning people who are intelligent, successful, um, have supportive families, so on and so forth, are gonna have challenges, right? Everybody has problems, um, and in various degrees, and I think they come in waves. But I think how this comes out on a micro scale, for example, um, in the work that I do, is we want to create spaces where people can share their own experiences. And people don't need to frame it necessarily as a mental health problem, but it helps improve their mental health by being open about it. Um, and what I'm doing personally is, something that keeps me well is physical activity and basketball. And I noticed that with the weather getting colder, we play outside for the most part. We need to migrate to an indoor gym soon. But something I bring up nowadays is, well, I think this space is an excuse for us just to get together, to do something, to have a sort of routine agency over our lives when everything seems to be out of our control, right? The federal government, with its funding and so on and so forth. What can we do on the micro scale to take care of each other, right? And with our guys, I'm just starting to get to know a few of them. We're not so open about talking about our challenges, but I think people do people don't just want to play basketball, they want to talk about their lives. They want a space where they can be open about issues they're facing, right? So it's just about having conversation, making it feel normal, because it is.
Any more? Other questions in the room? I know I saw a couple hands.
I was trying to.
No, you go first, and then we'll take a question. We are not cutting off a panelist.
No, I was just going to say, like, the work of Dee Dee's Cry, that's what we try to do, is to normalize the conversation about how everything affects our mental health. So we'll do panels about finances and mental health, and hair and mental health, like just how our own appearance affects how we see the world, how we face the world each morning. So when we talk about housing stability, I think of it just like a relationship. If you're secure in that relationship, you blossom. If you're secure in your housing, you will blossom in other ways. You will blossom at work. You will blossom with your family. And I want to say it just on a good note, just all the people who are working out there, the community organization, people in this room, just even having this panel, this conversation, who are working to support people who are facing housing instability. And just want to say, just keep up the good work.
Thanks.
Hi, I'm John Beam with Immigrant Family Services Institute. Reflecting, Toy, on some of your early comments, as well as the work that some of my associates do, housing support is highly bureaucratic. And understanding, at least for the moment, that that needs to be there. Thoughts on how flexibility or understanding could be built into the bureaucracy a little bit more?
I'll start that. I think you're right on. I think it's very difficult. And I say this to my staff a lot. It's easier. I'll say it differently publicly, but it's easier for someone who has less barriers to housing to figure out the system than it is for a single parent who is couch surfing with mental health issues or children that are failing in school, et cetera. And because of that, we are doing it incorrectly. I mean, so I'll own that. I think over the years, a lot of organizations and governments have tried to make applications easier. All the listings in one place, one number to call if you want to buy a home in the city, one number to call the Office of Housing Stability if you're in your rent, you're a renter and all of a sudden it's been a fire or you're behind in your rent. So I think we've really tried to make our systems work for people better, but we are not there yet, especially when all our affordable housing has like 7 to 10 funding sources and they all require different things from different people, right? So it's just, so I apologize. I mean, I work for the government and I apologize for how difficult it is, but lotteries are becoming easier. We're thinking about now application portals, like put your application in. Yes, I want these, and just so it's automatically populated. So I will say, at least at the Mayor's Office of Housing, we're thinking about this issue on a very, very regular basis. I also want to start making, not all of the new housing resources or housing developments that are coming online available. Like they've got to be available to the general public. Otherwise, the general public loses interest in continuing to fund and build affordable housing because their kids may not get in there. And, but I do want to start setting aside, and we're working on this, new housing developments that are coming forward or coming online soon for folks that are rent burdened or folks that have other challenges. So even if it might take them a little longer to get there, there's going to be units setting aside for them. So I do hear that. I own it. I feel it. And we're trying to be better. But I don't know if any of the panelists have any ideas or thoughts on that.
It's not actually an idea. Where I live, there was an apartment across from me that was empty for over a year.
Ooh.
So of course I'm thinking these wait lists is not actually, It's the turnover. Because I'm like, if this one apartment's been empty for over a year, what about the floor above me and that other floor above me and just across the city? That something needs to be in place just to make sure that these management companies have a better turnover.
Yeah.
Because why do people have to be on a wait list for 6 years for an apartment if one been empty for over a year?
I
You
want
know,
the
so
address. Give me that address after we're done.
so just want to state that.
No, thank you. Thanks. Any other? Thanks. Yeah.
I also think we need to redefine affordable. But my son makes $60,000 a year, and he went to get an apartment, and it was $15,000. So he was above the tax credit thing by $5, whatever it was. So he couldn't lease a tax credit, but it was him and his other half. And so when they put it together, it was too much. But it was $15,000 just to get into the apartment. I'm like, nah, stay here for a year and we're gonna buy you a house. It was easier to do that than it was to get them into an apartment. So we started to think about people. He's making 60, his other half, she was making 60, but still they couldn't really afford an apartment. They were not going to be rent burdened on. So we started to think about workforce housing, affordable housing, all those other pieces. We really need to define what that looks like, because it is bureaucracy, right? It's a business, right? Everybody's about making money, right? And so as generations change, right, even in this affordable thing that we're talking about, and as people that are buying it and people that are building it, they want different outcomes, right? And so it's not as much about in the past where it used to be about having opportunities for those that are low or moderate income. Now it's about how is it going to make me money? How is it going to build my generational wealth and other pieces that I'm looking at? So how do we start to think about that is my deepest concern right now. When I start to look at my grandson and other pieces and what environment will they be living in when it comes to housing, and will this state have enough housing for them as time continues on?
Great, thank you. Thanks.
This doesn't exactly get to the sort of like the burden piece of it, but I just did want to give the city a shout out. Boston Housing Authority is particularly a shout out, because I think there is great innovation happening. For example, just your point made me think of it. And I'm going to get the name wrong, the Section 8 homeownership program.
Yeah, I forget the program name too, but people are using their vouchers to actually purchase homes.
Right. So they're allowed to use their vouchers, basically sort of like a rent to own kind of thing, but with the Section 8 support to be able to apply that towards a mortgage. But still with the percent of income, right? So the 30% of their income, rather than what, if you were on the private housing market, you have to be paying a much more, and sort of helping people transition into home ownership and build generational wealth. So, again, I think it gets back to this point about like not getting stuck in how things are now, but really like, how do we explode those borders and think about things really differently? I know this big nonprofit housing organization, National Enterprise Community Partners, has and again, I'm going to get the name wrong, I apologize. The sort of like a renters equity fund where, renters are paying in their rent and building their landlords generational wealth and building their landlords profits, right? And so it's a setup where renters get a portion of the equity, like a percentage of the equity that gets put aside for them, so that you're not paying rent into a void, but actually building wealth too. So I just think we can be creative, but it does require, to your point again, Sheila, bringing people from all different sectors to think together, which we're doing today. So yay.
Thanks.
Okay, any last question in the room for now? If not, we're going to go to a couple online.
All right, from online, we have considering the upcoming changes to federal programs that many of our patients rely on, and it can probably impact their housing stabilities. Are there any preventative measures we can take to help prepare ourselves and our patients for these changes? Do you think Massachusetts will be prepared for these changes?
So I'll start because we're thinking about this nonstop. At least I'm thinking about. I can't speak to the changes with healthcare, which I'm sure you're all very, very worried about, and hopefully, like some very rich conversations are happening. The if some of the housing threats come due, we're meeting with all of the providers. We're meeting with our shelters. We're meeting with folks working with those hardest to house and having sort of what if conversations. There isn't a local solution. The problem is so big. I don't want to be doomsday right now, and we will. I should say this, but if what folks are threatening around housing comes due, of course we're going to do everything we can with other cities and towns to fight back. We have the Wu administration has been successful in a lot of legal challenges to some of the regulatory and the financial threats that have come our way. But right now we're sort of thinking about like worst case scenarios in what we do with thousands of unhoused people. It's that scary. So I won't say I have a solution or we have a solution collectively. I will say though that everybody's meeting on a very regular basis, trying to come up with what ifs.
And I just want to be clear, and just in case those who don't know, and I know at one point the administration, the federal administration, said they wanted Section 8 to only be for 2 years. So if you've been on Section 8 for longer than 2 years, you will get thrown off. And if that was to come to fruition, just imagine just all the homeless people there would be in Boston. Because the rents are really just too high that if you don't have a subsidy or don't have HUD housing, you really can't afford to live here.
Right.
So yes.
I think, and this is my own opinion, I don't know, I've heard that too. Section 8 might fare better because there are so many private developers and owners that rely on it for their portfolios. I'm thinking it may fare better than other programs, but like who knows? It's just my prediction.
I just wanted to sort of weave in another thread that from the panel this morning. I think setting aside the housing funding issues, which are giant and scary, the other way that I think we're going to see a big housing instability crisis is people losing health insurance, because health insurance and housing stability are so tightly intertwined.
That's true.
And I know that the government shutdown is causing an enormous amount of pain. And the source of the shutdown is around these premium credits and other aspects of health insurance that, if people lose that coverage and the, provider taxes go away and all these sort of like wonky, weedy things, like basically the bottom line is millions of people losing health insurance. And in turn, we're going to see a giant spike in housing instability. So the two fights are, tightly intertwined. And I know that the state is doing a lot of thinking and planning, not just on housing, but also around health insurance and what can the state do to sort of buffer folks here in Massachusetts. But yeah, those are two sort of twin demons there.
One more online.
All right. So housing for those with severe mental illness is complex. They may have been evicted from their homes, from homeless shelters, from housing services, etc., because they aren't stable enough. And so really thinking about how can we address this issue?
So I'll just kick something off and then certainly if the panelists can add. Boston has been doing I think a very, very good job of building more permanent supportive housing for folks that are currently homeless. Mostly individuals, but some family housing. And under the Wu administration, we've been able to really add hundreds and hundreds of units throughout Boston using new construction, building hundreds and hundreds of new units that also are using rental subsidy to keep the rents very, very low, and very, very rich services. And the way that the system works in Boston is that when we go to fill up with those new developments, we're looking at homeless that have been homeless for very long periods of time. And that's probably because they've had so many barriers to getting housed, along with sort of disabilities and mental health and substance use disorders. So making sure that the folks that need the rich services the most are getting those units. So I think we need to continue to do that, because for a lot of folks, some folks will live independently and they just need an affordable unit and they need supports. For a lot of our residents, they really need ongoing daily supports, and that comes through independent living, but through permanent supportive housing. I don't know if the panel has anything to add.
Yeah, one of the housing agencies that I know about, as part of their loans, they have a 3% set aside for those with mental health challenges. They work with the Department of Mental Health, and 3% of those apartments that are developed out are set aside for those particular communities and those with those types of issues.
Yeah, I'd quickly add that having sort of residents who may pose challenges to them, not only to themselves, but also to other residents, is a challenge for us, and it happens every once in a while within our units. But we're thinking about ways in which we can partner with a social service provider, right? More often than not, the residents will come referred through that program. So how do we work with them to get them the services they need, whether it's within the units, whether it's at an outpatient program, or maybe just a program in which they can surround themselves with other people and not be isolated, right? And have some sort of social interaction, whether it's with other seniors, for example, or with other colleagues. So just thinking about holistically, what are the gaps that need to be filled outside of some of the mental health challenges they're facing.
I really want to thank this entire panel for this incredibly, I think, powerful and important discussion. Our moderator, thank you so much. And I want to say we are now about to start to take a lunch break, a few housekeeping things, and one exciting announcement. So please join us in finding a lunchbox in the back. Please allow those who identify as vegetarian or vegan to have first pick of the antipasta option and falafel option. I'm doing my job, right? Please take a few moments, if you're someone who might have to sneak out a little bit early, to use the QR code to fill out our evaluation online. But I also want to encourage you, please not to do that if you're able. After the lunch break is when we start to really think about how to move from this to action. It's going to be a really exciting part of our day. And lastly, I just want to announce that I am very excited to have two wonderful youth performers joining us. I'm assuming these names are the people who are out there, but I have not confirmed. Jo Saza and JASSIEL from Beat the Odds. Beat the Odds serves under-resourced youth in Boston, ages 14 to 24, through its creative youth development program that uses music and the arts to help young people explore their creativity, build self-awareness, and support healing from trauma. They will perform their work with us, which is centered on uplifting mental health and wellness. Please feel free to move about while they're performing, grab your lunch. They'll join us soon, use the restrooms, visit the tables out front. But for now, I really want to give one final round of applause to our panelists and our moderators.
Can I say one more thing? Can I just say one more thing? Don't forget to take care of yourself, 'cause this has been a difficult morning with some tough subjects that you deal with each and every day. And so I just want to remind you, when you talk about outside, whether you want to go out here and sit or somewhere else, just breathing exercise, whatever you do to take care of you, make sure before you leave this space to do something for yourself before you get back home. And I just wanted to remind you of that. Thank you.
Yo, Northeastern, that's where we at right now, right? All right. The mic was messing up on me. So can I get a year? Year. Y'all seem a little bit significantly older than me. So I'm gonna make sure. Hey, nah, that's a good thing, though. I'm gonna make sure I rock out with y'all appropriately, all right? So when I say E, y'all say V. V, like ethereal visions. See, I'm a 17-year-old artist from Roxbury. I represent a movement called Ethereal Visions. We're an independent label, Black owned, Black made, and that's what we pushing. So let's go. The first track I have is called Grow Up. It's about me growing up, and I don't know, it's self-explanatory. Y'all gonna get it. Let's go. So how y'all feeling? Feeling good? All right. I see some brothers and sisters. I see people from all different type of places on the globe. You know what I'm saying? I'm a little nervous. Yeah, I was like, all right. Yeah. I think the mic gonna mess up, but we just gonna rock out. Let's go. Hey, I said, I don't got no friends, but the money mends my wounds. Seeing through the fools that tried to play me, in the end, I'm still him. Heard they tried to kill him. Is it cause he well fed, well dressed? Brother, God forgive him for times he sinned. He wanna be a kid. With that, he was running around. By the ignorance, it was the one of the time. Ain't nobody help me up. Cut my knee and scrape my hands, but ain't nobody patch me up. And I left scars and bruises. Yeah, this mic is kinda useless. Yeah. And when I fell down, ain't nobody. I ain't gonna lie, this mic messed me up. Let's just hit the next track. I ain't gonna lie, I'm gonna do this acapella too.
Gotta hold it a little bit further from your face. I'll put it up. It's like
Yeah. Okay. So we're gonna let's get the next track. It's all good. Listen, I'm not gonna lie. That last track is a little bit old. Mic kind of slow, so we're just gonna get this next one. So raise your hands in the air and say yeah. Yeah. Say yeah. Yeah. And say oh. Oh. The mic slow. I said, life been changing, no time to be wasting. Gotta get funds, young brother campaigning. City on lock, to the world we done waiting. Can't wait to get famous. For the room with champagne to just think about how misled I've been through my mishaps. Try to grow into a better person. And I did that, but still my soul hurting. Cause what I asked for ain't aligned with my purpose. At least I know that God is as real as his word is. I said, had to grow up fast for my baby sis. I can't protect you from the bad. That's just how we live. And since Pops left, I had to stand up. I'm 7. Young brother like me and make I hold out Bible. Not even trying to be. I said bye, girl. Lord, I got no time for five. I've been rocking all black, no tie on my man took his car. Put no job, bro. I hope God forgets me, dog. I put my foot in the flow. And Northeastern, I wish we could have had more fun, but the mic's slow, you know. But I'm still funny, so we having fun. Yeah, we getting money, counting all the funds. Yeah, Jo Saza gonna run it up next. Good luck with this mic. I appreciate y'all. I could have did a lot better if the mic didn't slow me down, but we still have fun. Fair? 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 All right.
I might just kick this down. Make some noise for my boy JASSIEL. Can I get a yer? Yeah, I'm just gonna get right into the music. This first song I got is called Hard Time. I wrote this while I was going through a lot in life. I done overseen. Yeah. Yeah.
Brayton Weatherman.
On a very independent self journey that I was on. I moved to Florida, went to school out there. And there was just a lot of testament to what I believe in today, and I experienced in those moments. So this song right here is really everything I've been through. Have a good one, y'all. Y'all make some noise for my Y'all make some noise for Jassy 2 more times. Hey. Yeah. So
Should I exit out of this? Okay.
One more round of applause. That was so amazing.
Can't handle it. Because that would be tough.
Oh,
Go ahead and go.
okay, so in a few minutes, Mo from HRIA will come up and help us transition to the action advocacy policy aspect, which will be interactive, so you can finish up your lunch, and he'll be with us shortly.
Otherwise, I'll let you be President Steve. Hey, y'all. Hello. Hi. Can we give my man Steve a big round of applause? He's made the tech happen. Thank you, Steve. Good afternoon. My name is Mo Barboza. I'm here from Health Resources in Action. Our team has been helping in the background and also supporting the almost 100 folks that were online with us as well this morning. So it's been great. Hopefully folks had time to grab some lunch, maybe visit some of the tables. I know because I saw y'all talking to one another. That's a good thing. We'll always support that. We're going to move into the afternoon. Part of our afternoon activity is to dive deeper into some of the things that were talked about this morning, and we have some questions that we're going to be asking you to consider. So, but the first thing is, how are we going to get into groups? How many of you have all played Uno before? Uno? If you raise your hand, your elbow is straight. Let's try again. Straight up, there you go. All right. That's almost straight. It was like a little bit there. Okay, no worries. All right, so I'm going to give you a Uno card. We're going to be separated by colors and wild cards. Okay, so you're either going to have a color or a wild card, and that's going to be your group. And then we'll be sending you to one of these questions to get you started. So I'm going to pass out our Uno cards first, and then we'll go over the who's going to what questions. You're going to get about 10 minutes at each question, and there'll be somebody there to scribe and then you will rotate, but I will tell you when to rotate. There's always those early rotators. Don't be that person, John. All right. I will tell you when to rotate. We just want to make sure that everybody gets a chance at their local space. So I'm going to come pass these out, and then we're going to get rolling. Our friends online, they are also going to be in some breakout rooms doing these same 5 questions. All right.
What is it? Oh. So I just have to get them some apple crisps. Oh, sure. You got a minute? Yeah. Okay, wonderful. I'll be right back. You want pull up a rocking chair? I ran out of vanilla ice cream. Just have to grab it downstairs.
All right, is there anyone who did not get a Uno card? Okay, everybody who did not get one, great. So I'm going to go off of this microphone so that I'm not disturbing the people online.
That thank you. The cool thing about sonnets is that they're supposed to have a volta. So a volta is like a turn. So what makes a sonnet, and you see it a lot in American sonnets in particular, but what makes a sonnet is that it turns. It has like a shift that takes place in it. So yeah, this is called sonnet to yield laughter. Look, Ma, I can smile, huh? There's gold in my teeth and ain't none of them wrapped in foil. The grill get hot trying to look at me. I'm starshine, a gold line, a gold sign, a gold tree. Every letter in my name, a gold simile. Periodic tables stay trying to jack my swag. The only orphan parts of me must be the fire I nabbed. Look me in the eye and say your soul ain't brighter, 10 times lighter, mustard splattered. What colors grief so messily to leave laughter out the line? Greatest riddle I ever told was trying to hide my shine. Ha! There was a time I wanted to die. Ha! And here I am, alive, alive. Cool. I'm going to read one more poem. It's a draft, but living poets work on things, and this is something I'm working on. I am bipolar. I had a manic episode when I was in college, and it kind of just changed everything for a period of time, and then forever after that. And so, yeah, I've been thinking about like that period of time and trying to write into it. This poem is called 6 Selves I've Been, and sort of like reflecting on like different moments in my life. And yeah, 6 selves I've been. 1, alive. In my mother's country, a boy I don't remember, his antics or fully his language, the ones who carried him or his attachments to love. 2, newly American, and the language guttering out my beak, loquacious child, seeking questions, asking answers, comics, and honeycomb galore. 3, oh, what a time to be alive, this middle phase. So much burgeoning, so much becoming, so much terrible learning of survival through silence and the acknowledgement of one's peers. What a monster you could have become. What saved you? 4, is this the hardest face to look at? So much like my own, and yet I learned sophomore meant wise fool. I unlearned the sound of sun and relearned cicadas. Navigating at religion was my everything, its impossibilities, how feckless I felt, how irritable, how tinged with sunlight unseemly. You believed you were coming into knowing and yet had no handles over anything, crawling your way out of inherited violence without starshine to guide you, so much spew and uncertainty, unbefitting. When I look at you now, I grimace, flinch, slither stew away from you, parcel tongue my way out of recognition. The middle place was hard, but what to make of this unyielding drive towards becoming and failing again and again? 5. My mind bursts away from me like a runaway river, pulling at the dam, unloved and unanchored, our feelings to describe the chaos, but more so unheld in the ways you needed to be. You came apart, or things came apart in part because of you. Madness is the wildest field to leap into. It's the openness meadow. It's a brilliant clearing, everything crystallized in the brimming meadow of your mind. The world we're solving, you wanted answers, and they called to you. Loud, ferocious, crooning, teeth shining, pearly whites, you believed them and were swallowed whole. 6. Here, on the other side of 30, what a mercy to find folks to love you whole. Finally, here is a spot of land to claim home, a version of you to grow leaves through, to seed and regrow. There, finally, is the clearing you search for eternity, is realizing you are a seed, is finding and unfinding your roots. Thank you.
That's interesting that Jackie said that.
Yeah.
I'm a school librarian. I work at the Joseph Institute.
Oh, nice. Thank you, Emmanuel, and thank you for sharing your draft. That was amazing. Beautiful. So a little, it's gonna take me a minute. That was quite moving. So I just want to invite you as we wrap up to take a minute to open the virtual brochure, share your experience about today's summit by answering our 3 brief questions to help us get some feedback on this summit. We'll hope you'll enter your name and information and might consider staying in touch as we continue to think about how we can all support next steps in addressing the social determinants of mental health. I just want to say we have just all so enjoyed today, and a special thanks to Samara. This was truly your vision come to life. And, so happy to be along for this ride. And to all the teams, the Northeastern team, Samara's team, please take the flowers and items on the table as we leave. And we hope this, again, is the start of work we do together and not the end of a conversation. Anything you would like to add? So just, thank you, everybody. And where are you?